So after that half an hour of tug of war between this system and that system, I think finally we are back on YouTube, and I think this is supposed to be working fine, hopefully. And good evening, everybody. Yes, so I think now we should be okay. Just give me a feedback regarding the audio and the video, and then we are good to go. I think we wasted enough time already, and we will not be wasting any more time now, right? So I think, yes, of course, Nikhil, start from the beginning. There was no beginning only, right? We were not able to start only. Now I think we will start, yes. So Amit, Indrisha, Menalia, and Lekhya, and Syed, I think now that I'm taking your names, good evening, everybody. And let's get started with the session for today. Now the focus is today is on rapid revision. We've already wasted half an hour, okay, in this everything. So we are going to be very rapid. Focus is on one-liners only, okay. The LRR sessions, there are 2 sessions of LRR which were done on YouTube, okay. And those sessions I have covered in detail about amenorrhea, abortions, genital infections, obstetric emergencies, and ectopic. So, and a lot of clinical oriented topics were covered in the LRR session. So, I won't be talking about them in detail now. Okay, so let's begin. So I'll keep reminding you that this is something, if you want to revise this, go ahead and have a look at the LRR session. They're covered there in detail. All right, so the first one-liner, the hormone that is responsible for ovulation, the hormone that is responsible for resumption of meiosis 1, which is that hormone? Yes, which is that hormone? LH, excellent, LH hormone. And if they ask you that which hormone is responsible for folliculogenesis, then actually both FSH and LH are needed for complete folliculogenesis, okay. FSH, follicle stimulating hormone, so it is going to, initiate the folliculogenesis, you can remember it like that. But LH hormone is also very, very important for final maturation of the pre-ovulatory follicles. So ideally both these hormones are needed for complete folliculogenesis. If they ask you peak secretory activity, peak corpus luteum activity, they ask you peak progesterone levels in the serum, which day of the cycle? Any of the 3 things could be asked. Yes, day 21. Yes, excellent. Day 21 of the cycle. And they could ask it another way also. That would be 7 to 8 days after ovulation. 7 to 8 days after ovulation. And if they ask you peak proliferative changes, then what? Peak proliferative changes? Day 8 to day 10 of the cycle. Remember that proliferative changes are because of estrogen that is coming from the growing follicles, right? The growing follicles are synthesizing estrogen, the granulosa cells are synthesizing estrogen, and that is responsible for the proliferative changes, and secretory changes are happening because of progesterone. Okay, right? Remember this. Now, next, dash hormone is responsible for initiating the LH surge. Which hormone is responsible? If they ask you one-liner, directly responsible for initiating the LH surge? Yes, very good, estrogen. So, first what happens? Estradiol peak happens. Yes, excellent. Estradiol peak happens, and that is responsible for initiating the LH surge. But please also remember that maintenance of the LH surge needs both estrogen and progesterone. Okay, remember this as well. This is an extra pointer. If they ask you LH surge occurs approximately how many hours prior to ovulation? Approximately how many hours prior to ovulation? Yes. approximately 36 hours prior to ovulation. Next one liner, hormone supporting the corpus luteum in the non-pregnant state and during pregnancy, right? So in the non-pregnant state, which is supporting corpus luteum? Which hormone? Yes, you can answer it like, give me two answers. In the non-pregnant state and during pregnancy. Supporting corpus luteum. Supporting corpus luteum is HCG, not progesterone, is HCG. Corpus luteum is going to secrete progesterone. Okay, corpus luteum is going to secrete progesterone. It is it is LH hormone in the non-pregnant state that is supporting the corpus luteum, and hormone supporting corpus luteum in pregnancy is HCG. Please remember that HCG is structurally very similar to LH hormone. Remember this extra bit pointer also. Okay. Now, lifespan of corpus luteum in the non-pregnant state. Lifespan of corpus luteum in the non-pregnant state and in the pregnant state. How do you remember? It is 10 to 12 days in the non-pregnant state and it is 10 weeks in the pregnant state. Okay? Yes. Alicia, in a Viva, I would say 12 to 16 days I will give you marks, right? But in your MCQs, again, we have to be very precise. So it is 10 to 12 days, okay? All right. And Sushi, when you say 14 days, no, it is the duration of luteal phase that is fixed. The duration Yep. So what was I telling you? I was telling you, yes, you will get the PDF. Don't worry, you will get the PDF, right? So I was telling you that it is the duration of luteal phase, the second half of the cycle, that is fixed at 14 days, right? So when you have regular cycles, okay, whatever is the cycle length, okay, whatever is the cycle length, from that cycle length, if you subtract 14 days, you can predict the day of ovulation. You can predict the day of ovulation. Like for example, if somebody is having regular 28-day cycles, okay, then the ovulation day is on day 14. Similarly, if somebody is having, let's say for example, 32-day cycles, but regular cycles, right? Then the day of ovulation would be 32 minus 14, like day 18. Got it? Fine, very good. So you all know this. And if I say that somebody is having irregular cycles, that means anovulatory cycles. That means anovulatory cycles. Remember this extra point as well. Okay. Now, moving on. Next one liner. Hormone responsible for milk synthesis. Yes. Hormone that is responsible for milk synthesis. Yes. The main hormone, see, many hormones are responsible for milk synthesis, all right? And many hormones have got a role to play. But the main hormone, or let's say they will ask you, which is the essential hormone for milk synthesis? Excellent, it is prolactin. It is prolactin. Okay. Hormone responsible for milk ejection reflex or milk let down reflex. What is that hormone? Hormone responsible for milk ejection. Very good. Oxytocin. Oxytocin. And somebody said estrogen and progesterone. What were you talking about estrogen and progesterone? You were telling primer. Med student was saying primer by estrogen and progesterone. So estrogen and progesterone is responsible for the proliferation of the milk secreting apparatus. Like estrogen is responsible for the proliferation of the ducts, and progesterone is responsible for proliferation of the alveoli, but only after estrogen priming. Okay, fine. Now, hormone that is responsible for lactational amenorrhea. Hormone that is responsible for lactational amenorrhea. Yes. For lactational amenorrhea. Yes, prolactin. Very good, prolactin. How does it happen? Prolactin, what does it do? It inhibits pulsatile GnRH secretion. Pulsatile GnRH secretion. Okay, remember this, very, very important. Also remember oxytocin hormone. Okay, when the woman is breastfeeding, right, when the infant is suckling on the breast, woman experiences these crampy pains in the lower abdomen, in the puparium, due to uterine contractions. Which are those pains? Yes, which are those pains? Those are after pains. So, hormone responsible for after pains during puparium, that is the same, oxytocin. Okay, remember that as well. Next question, contraception of choice in lactating women. See, if it is a blanket question, that means nothing else is mentioned. If it is a blanket question, nothing else is mentioned, you can answer progesterone only pills. The only reason that progesterone only pill is the answer is that they can be started soon after delivery. Okay, but this is a very old question. Okay, now they are asking you questions like contraception of choice in first 48 hours postpartum. Within first 48 hours postpartum, if you have the choice, then copper T is the contraception of choice. That is going to be the answer, because Government of India is promoting that. Okay, and like you said, why not barrier method? Dekho yaar, barrier method, the only reason why it does not feature in contraceptive of choice is because of the higher failure rate as compared to these hormonal methods of contraception or copper T, right? At 6 weeks, postpartum, that means they will tell you that a woman is coming after delivery, and 6 weeks postpartum actually they mention because that is the time when women visit us, for the postnatal visit. So 6 weeks postpartum, remember it like that. What is the contraception of choice now? At 6 weeks postpartum, everything seems fine. It's copper T. Okay, otherwise injectable DMPA. Okay, and remember oral contraceptive pills. Oral contraceptive pills, they are not used in breastfeeding women till 6 months. Till 6 months, we do not prefer to prescribe oral contraceptive pills to breastfeeding women, and till 6 weeks in those who are not breastfeeding. Even in those we will not prescribe. Okay, even if they are not breastfeeding, if they are within 6 weeks postpartum, we do not prefer to use oral contraceptive pills. Remember these extra points as well. Now they have asked you this question in your exam: hormone detected by home-based pregnancy test. Right now, Dheeraj, only breastfeeding, already physiology. Now if she is only breastfeeding, no. See, if she is exclusively breastfeeding, let me make that very clear. Dheeraj, your doubt about this is that women who are exclusively breastfeeding, you are talking about lactational amenorrhea, that is fine, right? But lactational amenorrhea also has got a failure rate of 2%. Okay, so it's not like if they are lactating, they should not take any contraception. No, even women who are breastfeeding should start some form of contraception in the 3rd postpartum month. Okay, keep that in mind. Okay, now hormone detected by home-based pregnancy test. This was a recent FMGE question. Yes, HCG, very good. HCG, hormone that decreases after the first trimester. Hormone that decreases after the first trimester. Shivam, progesterone only pills, they will not come under oral contraceptive pills. When they say oral contraceptive pills, they are talking about combined oral contraceptive pills. Okay, fine. If they are specifying progesterone only pills, they are containing only progesterone. Alright. Now, hormone that decreases after the first trimester in pregnancy. All hormones tend to increase throughout pregnancy. One hormone that decreases after the first trimester is HCG hormone. Okay. It peaks at 8 to 10 weeks of gestation. It is first detected in maternal serum at around 8 days after fertilization. It peaks at 8 to 10 weeks of gestation. After that, it starts to decrease and then plateaus at around 16 weeks. Okay, fine. Hormone produced in maximum amount by term placenta. Yes, hormone produced in maximum amount by term placenta. Very good. Human placental lactogen. The role of human placental lactogen is in maintaining insulin resistance. Please remember another very, very important pointer. Human placental lactogen, this hormone indicates placental well-being. Remember this one-liner pointer also. Now, if they ask you what is the raw material for progesterone production by the placenta? Raw material for progesterone production by the placenta. Yes. Raw material. Not androgen, Shivam. For progesterone production by placenta, it is LDL cholesterol from the maternal serum. It is LDL cholesterol from the maternal serum. Okay, fine. And for estrogen production by the placenta, then the answer is DIA S. From fetal adrenal glands. Okay, clear? Alright. Now, if they ask you what are the estrogen forms that are specific to pregnancy, meaning that they can be found only in the serum of pregnant women. Estrogen forms specific to pregnancy. What is your answer? Yes, if you have to pick one, it is estetrol. Pick one, E4. Otherwise, yes, E4 and E3. If you have to pick one, it is estetrol. Otherwise, yes, E4 and E3. Clear? The most potent form of estrogen, the predominant form of estrogen in reproductive age group women is estradiol. Remember this also, is estradiol. Right? So, very good, you all know this. Alright. Now, moving on. The hormone that is preparing the endometrium for implantation, if they ask you this, or they ask you the hormone that is responsible for decellularization of the endometrial lining during pregnancy, what is that hormone? Not estrogen, it is progesterone. Not estrogen, it is progesterone. Progesterone is the answer, not estrogen. Bache, preparing the endometrium for implantation. The second half of the cycle, remember progesterone, right? So, what implants and what is the timing of implantation? This is an often repeated question. This should not go wrong. Yes, what implants? It is the blastocyst that implants, right? And the timing of implantation is, it's a range. Okay, it's a range. You remember the range. Sometimes, you know what they will do in questions, no? They will give you just one day. Like they will write 6 days, 7 days or whatever. When you remember the range, you average it out and answer if they are giving you, just 1 day. So you remember the range. And in your questions, in your MCQs, mark whatever is closest to that range, right? So it begins on day 6 of fertilization and is completed by day 10 of fertilization. This is the most accurate answer. Beginning on day 6 and getting completed by day 10 of fertilization. This is the most accurate range. In your MCQs, try to answer whatever is closest to this range. That is all that you need to remember. Now, in humans, it is a type of interstitial implantation. Okay, interstitial implantation means that the blastocyst, once gets implanted, it gets covered by the endometrial lining completely. Remember this term. Remember this term. Human implantation is a type of interstitial implantation. Remember this. Sometimes women can experience bleeding during implantation. It is not Piscasex sign. Yogesh is correct. It is Hartmann sign. It is Hartmann sign. Bleeding during implantation, but it is usually very mild and spotting like, so nothing to worry about it. Next question, next one liner, placenta develops from two sources, maternal as well as fetal. Okay, so placenta develops from, yes, what are those two sources from which placenta develops? One is decidua basalis, that is the maternal component. Okay, decidua basalis, and what is the other component? Chorion frondosum. Chorion frondosum. Okay, not parietalis, decidua basalis. See, if these basic one-liners get incorrect, what is the point, right? It is decidua basalis, not decidua parietalis. Okay, now next, very, very important one-liner question. What happens during early placental development? Spiral arterioles are remodeled. Okay, now these are crucial one words. First, spiral arterioles are remodeled. First, spiral arterioles are remodeled. Okay, in the region of decidua basalis only. Okay, and it is the extravillous cytotrophoblasts that invade the spiral arteries, not the syncytiotrophoblasts. Extravillous cytotrophoblast, not syncytiotrophoblasts. And this remodeling gets completed by 16 weeks. This remodeling gets completed by 16 weeks. You need to remember, extra pointer, this remodeling is defective. This remodeling is defective in preeclampsia. Particularly when we say early onset preeclampsia. Particularly in early onset preeclampsia. Now, what is early onset preeclampsia? Preeclampsia that presents or that develops before 34 weeks. That is called as early onset preeclampsia. Preeclampsia mostly develops beyond 34 weeks, but if it develops before 34 weeks, then it is called as early onset preeclampsia. Okay, good. So these are one-liner questions that have been asked in the past. Now, moving on, let's have a look at these images and let's see what sort of questions they ask you. Earliest finding of intrauterine pregnancy on ultrasound. Earliest finding. Look at this. First of all, a gestational sac will come. This is the outline of the uterus. This is the gestational sac. This is the endometrial lining. Can you see this gestational sac is eccentric in location? Okay. First of all, this sac would come. So, earliest would be the gestational sac. Okay. And it will be a true gestational sac. A true gestational sac will have double decidual sac sign. Double decidual sac sign would be positive. Okay. So, what is this double decidual sac sign? These two concentric white lines. Two concentric white lines. This is what is double decidual sac sign. Okay, two concentric white lines. Basically, these two white lines are coming because of decidua parietalis and decidua capsularis. Okay, so this is the earliest finding, remember that. Fine. And like, okay, and next when you are saying yolk sac, yes, earliest and most definitive sign. If they mention earliest and most definitive sign of intrauterine pregnancy on ultrasound, then what will happen? See, initially there was just a gestational sac, then a yolk sac will be seen inside. So one sac, inside that another small sac, that is called as the double bleb sign, double bleb sign, double bleb sign. That means there is a yolk sac inside the chorionic cavity. Okay, this is the earliest and most definitive sign of intrauterine pregnancy. This will, yes, confirm an intrauterine pregnancy. Okay, now cardiac activity is seen earliest by how many weeks on transvaginal sonography? Cardiac activity is seen earliest by how many weeks? Jatin, just so now that you mentioned, yes, Bagel sign is seen in ectopic pregnancy. Yes, you are right. Okay, so if they ask you earliest on transvaginal sonography, range is 5 to 6 weeks. Range is 5 to 6 weeks. I am talking about cardiac activity. I am talking about cardiac activity. Range is 5 to 6 weeks. If they force you to pick one, then you can pick 5 weeks if that is in the option. Range is 5 to 6 weeks. Okay, fine. Now, diagnosis of early pregnancy loss on transvaginal sonography can be made by seeing a gestational sac. There is a possibility that we can have early pregnancy loss, meaning there is a gestational sac that is more than or equal to 25 mm in diameter and it is still empty. The diagnosis will be early pregnancy loss. Or crown rump length of more than or equal to 7 mm and still no cardiac activity. This is how the diagnosis of early pregnancy loss is made. So you can see in this image here, this is the crown rump length being measured. This is the crown rump length being measured. Okay. Now, crown rump length is the most accurate parameter for what? Crown rump length is the most accurate parameter for what? It is measured in the first trimester. Crown rump length can be measured till 14 weeks. But for gestational age estimation, best seen between 7 to 9 weeks. Best seen between 7 to 9 weeks. However, crown rump length can be measured till 14 weeks, right? If I ask you, best for gestational age estimation, in the second trimester, 16 weeks, 20 weeks, then what is the answer? In the second trimester, it is BPD and in the third trimester, it is femur length. Okay, so these are one-liner questions that I believe you all know already. Yes. Now, moving on. Next one-liner, single most accurate parameter for fetal growth. What is the single most accurate parameter for fetal growth? Ideally, for fetal growth, growth scans are done. Okay, when we do a growth scan, we look at the estimated fetal weight. Okay, 4 parameters, BPD, femur length, head circumference, abdominal circumference, all 4 parameters are seen and a composite assessment of estimated fetal weight is done. Okay, but for fetal growth, which bones can nahi bache? Abdominal circumference. Abdominal circumference is the single most accurate parameter, abdominal circumference. Okay, so abdominal circumference or estimated fetal weight less than 10th centile for that gestational age would mean IUGR, Okay. Now, level 2 scan, which is the anomaly scan, right, is done between, it is the routine scan in pregnancy. It is done routinely in pregnancy. What is the timing of that anomaly scan, level 2 scan? Yes, 18 to 20 weeks. 18 to 20 weeks is the best range. If I say scan for placental localization, let's say for example, the context is that there is an anomaly scan was done. Okay, though it is a one-liner, I'll give you the context also. Let's say a routine anomaly scan was done, in that the placenta was low-lying or placenta previa was there. Now, you have to repeat a scan for placental localization. Very good. It is done in the 3rd trimester. Very good. It is done at 32 weeks. Very good, Ved. And at 32 weeks first, yes, for placental localization, if it is still low lying, then we will repeat at 36 weeks. Very good. Very good. Now, next question, next one-liner. Best for evaluation of growth restricted fetus and timing of delivery. What is the best investigation for evaluation of growth restricted fetus and timing of delivery? Yes. मतलब कि डायग्नोसिस हो गया है, डायग्नोसिस हैज बीन मेड, डायग्नोसिस इज ग्रोथ रिस्ट्रिक्टेड फीटस. Best for evaluation and timing of delivery. Ultrasound will help you with the growth scan, monitoring the growth scan. But if they say best for evaluation and timing of delivery, diagnosis has already been made. Diagnosis already been made. Doppler, fetal Doppler. Which Doppler? Umbilical artery Doppler. Doppler will tell you about the blood flows to the fetus, how the fetus is coping with the growth restriction. So, answer would be umbilical artery Doppler. Okay, fine. So, if you have absent end diastolic flow on Doppler, absent end diastolic flow on Doppler, and already more than or equal to 32 weeks, right, then we have to deliver the fetus. Then we have to deliver the fetus. Okay. Now, best non-invasive tool. Best non-invasive tool for assessing fetal anemia. What is the answer? Which Doppler? Okay, I am giving you clue also. Which Doppler? Which Doppler? MCA Doppler. Very good. So, fetal middle cerebral artery Doppler. What do we see in that? We see peak systolic velocity. What do we see? We see peak systolic velocity. Okay. Now, next, NT and NB scan. NT and NB scan, which is nuchal translucency scan. See the image. See the image. Nasal bone. Nasal bone. This white dot here. Nasal bone should be present, and this nuchal translucency, this is nuchal translucency. NT and NB scan is done between 11 to 13 weeks, 6 days. Very good. 14 weeks, you can remember that range. 11 to 14 is, all of you are correct, answered correctly. But I will give you very precise. It is 11 to 13 weeks, 6 days. 11 to 13 weeks, 6 days. That is the answer. Okay. Now, when we check nuchal translucency, with serum beta HCG and serum PAP-A, what is it called? It is called as first trimester combined screening. It is called as first trimester combined screening. And when we do the quadruple test, what is the timing for the quadruple test? What is the timing for the quadruple test? Quadruple test is done between 15 to 20 weeks. So, these are screening tests, right? And NIPT, is cell-free fetal DNA testing. Cell-free fetal DNA testing. It can be done any time beyond 10 weeks of gestation. Okay. So these are screening tests for Down syndrome. Okay. These are screening tests for Down syndrome. Okay. Fine. Now, what do we check in the quadruple test? In the quadruple test, we have 4 markers. HCG, maternal serum alpha fetoprotein, unconjugated estriol, and inhibin A. Okay. Also remember in Down syndrome, remember high, trisomy 21. Remember in Down syndrome, high. In Down syndrome, HCG levels are elevated and I for inhibin levels are elevated. Rest all are low. HCG levels are elevated, inhibin levels are elevated, rest all are low. Okay? In Down syndrome. Now, if the first trimester screen test is positive, what is the next investigation? And if the second trimester screen test is positive, what is the next investigation? इसको थोड़ा ठीक कर दो और ये थोड़ा और विजन में ले आओ, इसको थोड़ा एडिट. Yes. So if the first trimester screening test is positive, we perform chorionic villus sampling. And if the second trimester screen test is positive, then we perform amniocentesis, right? So CVS in first trimester and amniocentesis in the second trimester. Very good. And the diagnosis of Down syndrome has to be confirmed by this invasive fetal testing, and we take the fetal sample and we confirm by karyotype. Okay, so it has to be confirmed by karyotype. Now, next set of one-liners. Ultrasound finding of complete molar pregnancy, as you can see in the image. Ultrasound finding of complete molar pregnancy, as you can see in the image. Yes. Very good. Classic snowstorm pattern. Remember that there is going to be no fetus inside. Okay? No fetal tissue inside. Agreed? Now, most commonly, the karyotype with a complete molar pregnancy, what is the most common karyotype? Yes, most common karyotype. Dr. Hirpesh, how can we differentiate with OHHS? बच्चे OH डॉक्टर हाँ, सो OHHS का तो फिर इमेज में यूट्रस नहीं होगा ना, ओवरी में होंगे, खूब सारे सिस्ट होंगे ओवरी में, वहां से, और कोई क्लिनिकल प्रोफाइल मेंशन करी होगी. आंसर इज 46XX डिप्लॉयड 46XX, not 46XY. Please remember, it is partial mole, that is triploid, and that is most commonly misdiagnosed as missed abortion on ultrasound. Okay, fine. Next question. What is the treatment of choice for molar pregnancy? Treatment of choice for molar pregnancy. Incomplete mole, yes, the entire DNA is paternal. Ved Guru, complete mole, entire DNA is paternal. You are right. Treatment of choice is not methotrexate, it is surgical suction and evacuation. Suction and evacuation is your answer. Next one liner, ultrasound finding of ectopic pregnancy. Yes, so somebody had already mentioned in the chat box bagel sign. Okay, so understand here, ultrasound finding of ectopic pregnancy. First clue, empty uterus, pregnancy test positive with empty uterus and an adnexal mass. Most of the times it is a complex adnexal mass in the region of the adnexa, and there are certain name signs like bagel sign. There's one sign named bagel sign. Yes. Okay, like donut. Yeah, like a donut. And the tubal ring of fire sign. Tubal ring of fire sign. These are certain named signs. Okay. Fine. All right. Next one liner. Yes, now look at these images. Look at these images. What are we seeing here? They will have to tell you. They will tell you that a woman was presenting with this, appearance of the ovaries. What is this? Yes, very good. Now see, Gautam and Simran and Dr. Suha and Amit Kumar, OHHS. Ovarian hyperstimulation syndrome, you will get confused. But with ovarian hyperstimulation syndrome, they cannot ask you without a clinical context. So if there is OHHS, they will have to tell you something else also now. OHHS, they will tell you history of gonadotropin, ovulation induction with gonadotropin, HCG injection. Something of this information they will give you. Okay. Fine. History of IVF. Yes, IVF history will be there when that she is undergoing IVF cycle. Some clue will be there. Okay. Now here, this is polycystic appearance of the ovaries. This is polycystic appearance of the ovaries. Okay. Fine. Now when we say polycystic ovaries, it means there are numerous follicles. Please don't say there are multiple cysts in the ovaries. There are numerous follicles. Okay, these are bulky ovaries. These are bulky ovaries. Ovarian volume is more than 10 ml. Right? So it's not like there are multiple cysts in the ovary. There are multiple small follicles in the ovary, and bache, it is Rotterdam's criteria, not Amsterdam's criteria. Okay, and this pearl, string of pearl sign, necklace sign, the follicles can be arranged like string of pearls. That's okay. Okay, but it is the number of follicles which is important. Latest they are saying more than 20 follicles in either ovary. That will qualify. Number of follicles is more important rather than how they are arranged in the ovary. They may be arranged in this necklace like pattern. So earlier the original Rotterdam's criteria had 12 follicles mentioned, 12 follicles, more than 12 follicles in either ovary. Latest is more than 20 follicles in either ovary. What are the three things in Rotterdam criteria? 2 out of 3 should be present. You should be mugging it up. This is very, very important. Okay. So anovulation. Right? So, in menstrual cycle disturbances. Now, the menstrual cycle disturbances could be in the form of oligomenorrhea, delayed cycles, irregular cycle, amenorrhea. So, some abnormal pattern of menstrual cycle irregularity. Second is androgen excess. Androgen excess could be clinical. Hirsutism, raised serum androgen levels, raised serum testosterone levels. Okay, this would be hyperandrogenism. Please remember, obesity, insulin resistance, acanthosis nigricans, they are not part of Rotterdam criteria. Okay. The third criteria for Rotterdam criteria is the appearance of polycystic ovarian morphology. Okay. Clear? So, please remember this. Now, difference between OHHS and PCOS ultrasound finding is something that undergraduate students, you don't need to go into that. Just the image will not tell you, the clinical context will tell you. Okay, fine. and LH-FSH ratio in which the LH is raised, FSH is low, LH-FSH ratio is not part of the Rotterdam's criteria. Okay? Fine. Now, first line treatment for women diagnosed with PCOS. First line treatment for women diagnosed with PCOS. First line treatment. Very good, Dr. Vedguru. It is lifestyle modification. Lifestyle modification. Okay, so whether a woman is wanting to conceive, whether a woman is not wanting to conceive, it doesn't matter. First line treatment is lifestyle modification. Yes, if they ask you drug of choice for PCOS in a woman who's not wanting to conceive, who has irregular cycles, who has hirsutism, it is oral contraceptive pills. It is oral contraceptive pills, answer for both. And they have also asked you what is the drug of choice for ovulation induction in PCOS. Drug of choice for ovulation induction PCOS, letrozole, if that is the option, that is your answer. Otherwise, clomiphene citrate, both are first line drugs. Okay. Now, what is the drug of choice for ovulation trigger? Ovulation trigger. Trigger for resumption of meiosis, for ovulation trigger. What is the trigger? It is HCG injection. HCG injection, very good. HCG acts like LH. Okay, fine. So these are important one-liner MCQs. Let's move on. Next set of one-liners, main mechanism of action of oral contraceptive pills. What is the main mechanism of action of oral contraceptive pills? Main mechanism, they work by various mechanisms, but the main mechanism of action is inhibition of ovulation, inhibition of ovulation. Okay, so gonadotropin levels, that means the FSH and the LH levels, they are suppressed, right? FSH and LH levels are suppressed. Yes, Yasmin, better instead of saying artificial periods, it would be better to call it as a scheduled withdrawal bleeding. Right, that would be the correct scientific terminology. वो ज़्यादा सही तरीका है scientifically उसी बात को बोलने का. Now, oral contraceptive pills and cancer risk. Oral contraceptive pill and cancer risk. So I'll just write again, inhibition of ovulation and your FSH and LH levels, they are suppressed. Okay. Now, OC pills and cancer risk. Increased risk of cervical cancer, and that is adenocarcinoma, not the squamous cell cancer, and increased risk of hepatic adenoma. Hepatic adenoma is very rare and it is benign. And please remember, oral contraceptive pills are protective for 3 cancers: endometrial, ovarian and colon cancer. Okay, as regards breast cancer, there is either no increased risk or maybe slightly increased risk, which is also maybe. Okay, fine, clear? Now, next one-liner pointer. What is the contraceptive method with least failure rate? Contraceptive method with least failure rate. Yes. It is not tubectomy. It is not intrauterine device. It is Implanon. It is Implanon. Implanon is a single rod progesterone implant. It is effective for 3 years. One time fit, effective for 3 years. Contraceptive efficacy for 3 years. It is one single rod containing progesterone implant. Now, long acting reversible methods of contraception include, I think they are hiding behind my image, so I will just write them separately here. These LARC methods include implants, copper T and Mirena. Okay, include implant, copper T and Mirena. Injectable DMPA, Dr. Ved, tubectomy is most effective by Government of India. अब अगर Implanon option में नहीं होगा, then you can think of tubectomy as the answer. But most effective is Implanon. Yes, you are right. Implanon is not available in the Government of India supply free of cost for the woman. Okay. Now, DMPA, injectable DMPA, technically is not a long acting reversible contraception. Long acting याद करो, याद रखो इसको. Long acting reversible मतलब एक बार फिट किया फिर भूल गए. That is what long acting means. One time fit and then forget about it. Like Implanon, effective for 3 years. Like copper T 380A. Copper T 380A effective for 10 years. Right? Or multi-load. Multi-load is also a type of copper T, effective for 5 years. Contraceptive efficacy of Mirena, effective for 5 years. One time fit, forget about it. Injectable DMPA, we have to give, this comes under the trade name Antara, we have to give 150 milligram IM every 3 months. Every 3 months. So technically this is not a long acting reversible contraception. तो अभी एग्जाम में क्या पूछते हैं आपसे? आपसे पूछते हैं all are LARC except. उसमें लिखते हैं implant, copper T, Mirena, DMPA. Then your answer should be DMPA. Okay. Sometimes they give you options like implant, copper T, DMPA or whatever, and they write tubal sterilization. Then your answer should be tubal sterilization. That's how they have asked this question 2 times. Okay, all are LARC except. I am telling you DMPA is technically not a LARC, but if these are the options, then tubal sterilization for all practical purposes is considered irreversible. Okay, so tubal sterilization, ठीक है, women request reversal of tubal sterilization, all that, and वो छोड़ो. When we counsel the woman, we tell her tubal sterilization is irreversible. So tubal sterilization or tubal ligation is an irreversible method of contraception, and the site is isthmus. The site of tubal ligation is the isthmus. This is also an important point to remember. Okay, or isthmus क्यों? Why isthmus? Because isthmus is the narrow portion of the fallopian tube. The wall of the fallopian tube is also narrow at the level of the isthmus, right? Fine? Okay. Now, moving on. Next set of MCQs. Most effective hormonal emergency contraception. Most effective hormonal emergency contraception. Think. Most effective. If ulipristal is in the option, excellent, some of you are answering. If ulipristal is in the option, that's your answer. Otherwise, levonorgestrel. Otherwise, levonorgestrel. पॉइंट ये है याद करने का कि यूलिप्रिस्टाल के लिए एक तो इसमें डोज भी याद रखना 30 मिलीग्राम, लिवेनार्जेस्ट्रॉल 1.5 मिलीग्राम, राइट, सिंगल टैबलेट आती है. ASAP preferably within 72 hours of unprotected sexual intercourse, right. पॉइंट ये है कि यूलिप्रिस्टाल एसीटेट के लिए डॉक्टर प्रिस्क्रिप्शन चाहिए होता है. LNG is over the counter available. It is available over the counter. So that is why this is the one that is most commonly used also. Na? Make common sense. Okay. And yes, rightly said, I will just remove this. Wait. Yeah, rightly said, overall, most effective emergency contraception, overall, they don't not mentioning hormonal or anything, it is copper T. Please remember, copper T main mechanism of action is inhibition of fertilization. then inhibition of implantation. And copper T can be inserted within 120 hours of unprotected intercourse, unprotected sexual intercourse. Even ulipristal acetate can be taken within 120 hours of, or within 5 days actually, of unprotected sexual intercourse. Okay. So 120 hours of 5 days is the same thing. Now, next set of one-liner questions. Classic triad of endometriosis, wherever you see this, it could be in the form of a clinical profile also. Dysmenorrhea, dyspareunia, infertility. First thing should come to your mind is endometriosis. Ultrasound can show this. What is this? With typical, they will mention endometrioma, means endometriotic cyst of the ovary. Most common site of endometriosis is the ovary, right? And this is what is called as the chocolate cyst also. Can you see it is filled with dark chocolate brown colored old collected blood inside, hemosiderin rich contents, right? So that's why chocolate cyst. On ultrasound there is typical ground glass appearance. This is the typical ground glass appearance of the cyst. If they ask you what is the gold standard for making the diagnosis of endometriosis, gold standard is laparoscopy. Laparoscopy, preferably with histopath. That when we see on laparoscopy, preferably we take a histopath also, sample for histopath. But histopath is not necessary. हर बार histopath हो ज़रूरी नहीं है. हर बार हिस्टोपैथ हो ज़रूरी नहीं है. और डॉक्टर क्यूरियस, अगर सिर्फ एंडोमेट्रियोसिस की डायग्नोसिस बनानी है तो हिस्ट्रोस्कोपी करने की क्या ज़रूरत है? अगर आपसे गोल्ड स्टैंडर्ड फॉर डायग्नोसिस ऑफ एंडोमेट्रियोसिस पूछा जाए तो लैप्रोस्कोपी जवाब होगा ना, राइट? Because endometriosis में the endometriotic glands and stroma are outside the uterus, anywhere in the pelvis, right? Okay. Now, also remember here that for chocolate cyst, ये आपसे FMG में सवाल पूछा जा चुका है, asked in FMG for chocolate cyst, for endometriotic cyst, cystectomy treatment has the least risk of recurrence. When we do cystectomy treatment, it gives the least risk of recurrence as far as different treatments are concerned. Next set of one-liners. Screening test for tubal patency, gold standard for tubal patency and gold standard for pelvic pathology in infertility workup. Yes. So, screening test for tubal patency हमारे पास दो हैं. We have two screening tests. One is hysterosalpingography and one is sonosalpingography also. Sonosalpingography also. But generally we are doing hysterosalpingography in our setups. You should remember the timing of tubal patency tests. Timing of tubal patency tests. Whether we do hysterosalpingography or whatever, it is always post-menstrual. After the periods are over. Okay, it is always post-menstrual in the follicular phase of the cycle. We call the woman on day 10. Yes, Dr. Ved, day 10. So they will ask post-menstrual, pre-menstrual, follicular phase, which phase? This is the way they will ask you. Okay. Now, gold standard for evaluation of tubal patency is laparoscopic chromoperturbation, as you can see in this image. So, I have marked a star point, right? So, laparoscopy we are doing and we are introducing a blue dye. This is methylene blue dye, which is introduced via the cervix. है ना, methylene blue dye. And we can see it coming out of the femoral ends of the fallopian tube. Okay. Now, the gold standard for evaluation of pelvic pathology in infertility workup is also going to be laparoscopy. When we say pelvic pathology, so that is the advantage of laparoscopic chromoperturbation. Now we check, confirm the patency of the tubes also, and at the same time we can look at the condition of the tubes also. We can see how badly the tubes are damaged. We can maybe find evidence of genital tuberculosis. We can find evidence of endometriosis, right? Fine. Now, Dr. Ved, investigation of choice for PID. Investigation of choice for PID, my dear, will depend upon the context. Okay, so when we say the definitive criterias for diagnosis of PID, remember definitive criterias for diagnosis of PID. So the clinical context is there of like for example, clinical context of lower abdominal pain, adnexal mass, and then we have a tubo-ovarian abscess on ultrasound, right? Then we have, let's say, a patient with infertility, tubal blockage, right? Tubal factor infertility, and in that context, we want to look for evidence of PID, then it is laparoscopy. Right? Or let's say, for example, I can go on and on. For example, clinical context of acute abdominal pain, and we have suspicion the patient is not improving. We may have admitted, ended up doing a laparoscopy, diagnostic laparoscopy in a very sick patient, and pus is coming out of the fallopian tubes. So it will be on the clinical context when you ask investigation of choice. So PID is essentially a clinical diagnosis, and that's why I say that this is something that has been in detail done in the LLR videos also, and in my rapid revision lectures also. I have taken care that I discuss these clinical aspects with you. But let us please come back to the one-liners, okay, for now. Next set of one-liner, hyperprolactinemia. Hyperprolactinemia can present with menstrual disturbances, infertility, galactorrhea, even hirsutism or frank hypogonadism. So please remember, hyperprolactinemia meaning elevated prolactin levels outside of pregnancy and lactation. So more than 20 nanogram per deciliter, right? Sorry, milligram per deciliter, right? And excess prolactin is going to inhibit the GnRH, and that is how it brings about menstrual disturbances, anovulation, infertility, right? And also responsible for galactorrhea and even hypogonadism, right? So treatment of choice. Treatment of choice. They will ask you treatment of choice. What is treatment of choice? You will remember the causes also. Go with me, you will remember the causes also. Pehle batao treatment of choice. Treatment of choice is actually treatment of cause, common sensically speaking. Like for example, if the reason for hyperprolactinemia is hypothyroidism, treat the hypothyroidism first. Treat it first. If the cause of hyperprolactinemia is some drug, drugs like for example dopamine antagonists, then we will have to consider if we can stop or change the drug. Okay, fine. For example, if it is hyperprolactinemia because of prolactinoma, this is a pituitary tumor, anterior pituitary tumor, prolactinoma, right? Prolactin secreting adenoma, and you read about this in medicine. आप लोग इसे medicine में पढ़ते हो, surgery में पढ़ते हो. Surgical treatment से पहले prolactinomas को shrink करने के लिए क्या करते हैं? Drug of choice अगर आपसे पूछे, ड्रग ऑफ चॉइस आपसे कोई पूछे तो डोपामीन एगोनिस्ट. ड्रग ऑफ चॉइस आपसे पूछे तो कोई डोपामीन एगोनिस्ट. बाकी फिर हाँ आप सर्जरी में पढ़ते हो कि भाई अगर इफ प्रोलैक्टिनोमा इज एसोसिएटेड विद विजुअल फील्ड डिफेक्ट्स, है ना, स्पेस ऑक्यूपाइंग लीजन के साइंस एंड सिम्टम्स है, देन ऑब्वियसली वी विल हैव टू टेक अ न्यूरोसर्जिकल कंसल्ट एंड देन गो फॉर सर्जिकल. बट पहला तो फर्स्ट लाइन डोपामीन एगोनिस्ट, डोपामीन एगोनिस्ट. कैबरगोलिन is preferred over bromocriptine. Okay, so this is something that you read up in pharma also, this is something that you read up in medicine also, vagera vagera, right? And Suhasini, like you said, whenever there is hyperprolactinemia, physiological causes, जैसे कि taking the sample at the wrong timing, है ना, कि मतलब सुबह लेने के बजाय हमने बेसिकली शाम में लिया सैंपल वगैरह. वैसे तो प्रोलैक्टिन लेवल्स आर मैक्सिमम आफ्टर स्लीप, तो सोने के बाद तो किसी का प्रोलैक्टिन सैंपल लिया नहीं जाता. बट अदर देन दैट निपल स्टिम्युलेशन, चेस्ट वॉल बर्न्स, pregnancy and lactation, these are physiological causes of increased prolactin. So you definitely have to rule them out. And you definitely have to rule them out. So to rule out pregnancy, right, and all that. Next, set of one-liners. ये जो semen analysis के values हैं, ये आपको याद होने चाहिए. Right, you should remember these values. The count has to be at least 39 million per ejaculate. When we say concentration, that means per ml has to be at least 16 million per ml. Motility total has to be at least 42%. Progressive motility has to be at least 30%. And normal morphological point forms have to be at least 4%. So these are the lower limit of normal. Minimum itna hona chahiye, right? Now most important, I'll write again, wait. Okay, मोस्ट इंपॉर्टेंट पैरामीटर आपसे पूछे, सिंगल मोस्ट इंपॉर्टेंट. वैसे तो पूरी सीमन एनालिसिस की रिपोर्ट होती है इंपॉर्टेंट पूरी, लेकिन मोस्ट इंपॉर्टेंट, इफ यू हैव टू पिक वन, इट शुड बी मॉर्फोलॉजी, देन मोटिलिटी इफ मॉर्फोलॉजी इज नॉट इन द ऑप्शन, एंड देन कॉन्सेंट्रेशन. ओके, स्पर्म कॉन्सेंट्रेशन विच इज लेस is be called as oligospermia. If motility is less, then we call it as asthenospermia. If normal morphological forms, if there are abnormal forms are excessive, then we call it as teratospermia. Okay, generally in semen analysis we see a combination of things, oligoasthenoteratospermia, oligoasthenospermia, like that. Generally we see a combination of problems. Now, test to differentiate between obstructive versus non-obstructive azoospermia. Azoospermia means absence of sperms in semen. And the test to differentiate obstructive versus azoospermia, options mein they will give you different hormones, most likely. If you have to pick one, ideally a full hormonal profile is done. Ideally, a full hormonal profile, a urologist will also check up the male patient, and will take a thorough history examination. उतने detail में clinical बातें नहीं करनी अभी हमें यहाँ पे. One liner pointer, one best answer. Ideally, complete hormonal profile. If you have to pick one, it is serum FSH. If you have to pick one, it is serum FSH as the best choice answer. Okay. Fine. Not testosterone. Not testosterone. Testosterone level tends to fluctuate, and serum FSH will be a better this thing. Okay. So serum FSH and testosterone will be normal in obstructive azoospermia. Okay, if it is non-obstructive azoospermia, if it is testicular failure, there will be high FSH and decreased testosterone. And if it is pituitary or hypothalamic cause, which for male infertility is very, very rare, extremely rare, low FSH and low testosterone. Okay, so this I have given you extra pointer. Now, next set of one-liners. Infertile male, azoospermia, gynecomastia, small atrophic testes, low testosterone and high FSH. So, this is testicular failure. Right. Now, the fact that there are small atrophic testes, gynecomastia, then choose Klinefelter as your answer. Karyotype 46XXY. You will have to confirm by karyotype. You will have to go for a karyotype confirmation, definitely. Okay. Infertile male with immotile sperms, not necessarily azoospermia. They will mention immotile sperms. Immotile sperms, recurrent sinus infection, situs invertus may also be mentioned. It is very good. Immotile cilia syndrome, Cartagener syndrome, very good. Infertile male, hypogonadism. When they say hypogonadism, it in other words means that FSH, testosterone, they are low. That is what hypogonadism means. Red-green color blindness, hyposmia. Excellent. Coleman syndrome. Coleman syndrome. Okay. Next set of one-liner questions. First sign of puberty in females. First sign of puberty in females. And first visible sign of puberty in girls. So, first sign, if they ask you, it is growth spurt. And first visible sign is thelarchy. First visible sign is thelarchy, which is breast budding. Okay, fine. So, if they are not mentioning, visible sign, then if growth spurt is in the option, that's your answer. Androgen dependent change in puberty. Androgen dependent change in puberty. Yes, growth of pubic and axillary hair. Growth of pubic and axillary hair is androgen dependent change. Next, they ask you, what is the staging for grading of pubertal changes? What is the staging for grading of pubertal changes? There is a grading, there is a pictorial graph for breast development also, varying stages of breast development also, and for varying stages of pubic hair development also. Okay, stage 1 is prepubertal. Stage 2 is, let's say, breast budding has started. Some pubic hair have very fine, mildly pigmented hair have come, pubic hair. So, just started is stage 2, and then 3, 4, 5 is towards the adult stages. This is Tanner staging. This is Tanner staging. What is the grading for hirsutism? What is the grading for hirsutism? It is Ferriman-Gallwey scoring. Ferriman-Gallwey scoring. ओके इसमें जो मॉडिफाइड फेरमन-गैल्वे स्कोरिंग है वही आजकल यूज हो रही है. 9 sites are seen. 9 sites are screened. A score of more than or equal to 8 mean hirsutism is present. A score of more than or equal to 15 means severe hirsutism. Okay. Next set. Most common cause of, I think it is hidden. Wait. Yeah. Most common cause of puberty, menorrhagia. Most common cause of puberty, menorrhagia, they ask you most common cause of irregular cycles at puberty, delayed cycles followed by heavy bleeding at puberty. What is the most common cause of puberty, menorrhagia? Okay, this can be a direct question or they can ask you in a profile based manner. Okay, what is, yes, very good, anovulatory cycles, very good, anovulatory cycles. Most common cause of precocious puberty in young girls. Precocious puberty meaning that breast development is happening or any secondary sexual characteristics are developing before the age of 8 years or menses are happening before the age of 10 years. That is what precocious puberty means. What is the most common cause? Very good. Idiopathic, constitutional. Okay, just HPO axis gets activated prematurely. That is what it means. Dheeraj, congenital adrenal gland hyperplasia is not the most common cause of precocious puberty in girls. Congenital adrenal gland hyperplasia would be the most common cause of heterosexual precocious pubertal development. Heterosexual meaning girl developing, male type characteristics, so hirsutism and, androgen related changes and all that. So, most common cause of heterosexual precocious pubertal development. Okay. Drug of choice for precocious puberty. Drug of choice for precocious puberty. Yes. If we have to give a drug of choice, like Dheeraj, like Dr. Curious is saying that waiting and watching is an option. Yes, of course, waiting and watching is also an option, depends upon the age of the woman. There are various factors into play, family concerns and, all that. But other than that, if they ask you the drug of choice, it is GnRH analogues. GnRH analogues, right? So, GnRH analogues can be used in the form of GnRH agonist, because ultimately both of them lead to suppression of, gonadotropin synthesis, right? Okay, next set of one-liners. I'll just add these also. All 5 sets I will add together. Okay, menopause is a retrospective diagnosis. Okay, menopause is a retrospective diagnosis after how many months of amenorrhea? After how many months of amenorrhea? Yes, it's after 12 months. It's after 12 months of amenorrhea. Okay. Now, please remember, if they ask you hormone that is used for diagnosing menopause. Now, you tell me the hormone, I will tell you one very important point. See, when the woman is in the expected age of menopause on an average in Indian women is about 47 years. Okay, this is average. So, when the woman is in the expected age of menopause, you don't need to diagnose menopause all the time by checking the hormone levels. But yes, let's suppose I have to diagnose premature ovarian insufficiency, which was previously called as premature menopause. Okay, less than 40 years and she is having amenorrhea for 12 months. Less than 40 years and she is having estrogen deficiency symptoms. I am very concerned, maybe she has entered menopause prematurely. Then there is logic of using a hormone for diagnosing menopause, and AMH levels are generally lower in premature ovarian insufficiency. I agree with you. But ovarian AMH levels can be low with just poor ovarian reserve also. So, they are not going to diagnose menopause for you. It is going to be diagnosed by FSH levels, serum FSH levels, not even estradiol levels. Serum FSH levels more than 40 international units per liter on 2 occasions at least 1 month apart. Not even serum estradiol levels. Serum estradiol levels fluctuate. Serum estradiol levels in postmenopausal women will be less than 20 picogram per ml, but they will take time. They will often fluctuate. They will take time to come down. So, for hormone use for diagnosing menopause, answer is FSH. Okay, when menopause is setting in, when menopausal transition is setting in, you will also have inhibin levels, inhibin B coming from granulosa cells. They will also be lower, AMH will also be lower. Okay, so remember, recall that poor ovarian reserve ना, तो वो poor ovarian reserve हो रहा है आफ्टर द एज ऑफ 35, धीरे धीरे होने लगता है, फिर वही चीजें आगे कंटिन्यू करती हैं. व्हेन द ओवेरियन फॉलिकल्स आर डिप्लीटेड, मेनोपॉज सेट्स इन, राइट. तो वही पैटर्न चलता है, एएमएच लेवल लोअर, इनिबिन लेवल लोअर, राइट. ईस्ट्राडायोल लेवल फ्लक्चुएट करेंगे, गिरेंगे, समय लगाएंगे. आपका जो डायग्नोसिंग मेनोपॉज की बनेगी वो सीरम एफएसएच से बनेगी. ठीक है. नाउ, प्रिडोमिनेंट फॉर्म ऑफ ईस्ट्रोजन इन पोस्ट मेनोपॉजल विमेन. Estradiol is not the predominant form. What is predominant form? Estrone, E1, estrone, E1. Okay. Now, most consistent feature of menopausal transition, climacteric बोलेंगे या perimenopausal period. perimenopausal period. This is the few years, on an average about 2 to 8 years, on an average 2 to 8 years prior to the final menstrual period. पेरीमेनोपॉजल पीरियड में क्या होता है, मेनोपॉजल ट्रांजिशन हो रहा होता है. व्हाट इज द मोस्ट कंसिस्टेंट फीचर, और ये बिल्कुल बहुत वेरिएबल पीरियड होता है, ठीक है, किसी में कितना साल होगा, किसी में कितना साल होगा, इट्स वेरी वेरिएबल. व्हाट इज द, yes, some or the other form of, yes, you are right, anovulation will set in, some or the other form of menstrual cycle disturbances. So increased length of cycle, irregular cycle. सबसे पहले short cycle होती है, interestingly, initially short cycles, short cycle length, जल्दी जल्दी आते हैं period. Then yes, of course, different kind of menstrual cycle irregularity pattern, delayed cycle followed by heavy bleeding, all that can happen. So irregular cycle, menstrual cycle disturbances, वो एक साथ जोड़ लो, different patterns can be there. Now, most common reason for starting hormone replacement therapy. Most common reason for starting hormone replacement therapy. Yes. Hot flashes, very good. So, vasomotor symptoms, very good. Hot flashes, right, which are vasomotor symptoms. They happen because of estrogen withdrawal. Please remember that if the uterus is present, it always has to be estrogen plus progesterone therapy. It is not the same as oral contraceptive pills. Oral contraceptive pills dosage is entirely different. There are other kind of estrogen plus progesterone therapy that is given as a systemic HRT, that is different. And progesterone is always given for endometrial protection. Okay, if estrogen is contraindicated, then we think of giving SNRIs or SSRIs, but most of the times, yes, as long as estrogen can be given, it will be given. Okay, clear, right? And if the woman has only complaint of vaginal dryness, okay, some of you are saying na, hot flashes and vaginal atrophy. See, vaginal, these genitourinary atrophy, right? अब अगर सिर्फ genitalia में vaginal dryness जैसी complaint है, तो why should we give systemic HRT? If only problem is vaginal dryness, if only problem is genitourinary atrophy, then local estrogen creams can be given. Okay, topical estrogens can be given. Then what is the need for giving systemic HRT? Okay. And drug of choice for osteoporosis? See, when we give HRT for hot flashes, it will also give protection against osteoporosis. That's true. But in an older woman in whom already osteoporosis has set in, then the drug of choice for osteoporosis is bisphosphonates. Very good. Drug of choice for established osteoporosis in older woman is bisphosphonates. Okay, fine. Now, next set of one-liners. Initial investigation of choice for AUB. Initial investigation of choice. See, whenever you have abnormal uterine bleeding in reproductive age group woman, please rule out pregnancy also and pregnancy associated complications, that is given. But initial investigation of choice, yes, for abnormal uterine bleeding, no hormonal profile, first we take ultrasound pelvis. Answer is ultrasound pelvis. Ultrasound pelvis. Yes, and preferably a transvaginal sonography. देखो, एक बात ये समझ लो, before we'll move on to a break for 5 minutes. Remember this, when the uterus is a pelvic organ, When the uterus is still small enough, not that big enough, it is still a pelvic organ, all gynae scans, like for example, preferably transvaginal sonography. But when uterus becomes palpable perabdominally, then obviously you'll have to look at it on a transabdominal scan. Okay, right? Investigation of choice for AUB in young girls also. In young girls also, yes. इट विल डिपेंड, क्लिनिकल प्रोफाइल पे डिपेंड करेगा ना, काफ़ी कुछ क्लिनिकल प्रोफाइल पे डिपेंड करेगा कि भाई यंग गर्ल्स हैं तो अगर मान लो जो हिस्ट्री बिल्कुल कैरेक्टरिस्टिक है कि प्यूबर्टल एंड ओव्यूलेटरी साइकिल्स, सो इनिशियली बिफोर ट्रीटमेंट यू कैन स्किप द अल्ट्रासाउंड ऑल्सो, clinically speaking. But yes, an ultrasound pelvis would be a safe. And in young girls, I think you're asking TVS. हाँ, तो TVS नहीं. If it is a young girl, then one would not want to do a TVS. And then a transabdominal, right? Young girl भी मतलब sexually, inactive and जिनमें हम TVS नहीं करना चाहते, preferably वहाँ पे. अल्ट्रासाउंड होता है गायनी में. अल्ट्रासाउंड दो तरीके से कर सकते हैं. ट्रांस वेजाइनल अल्ट्रासाउंड होता है जिसमें प्रोब वेजाइना में डालते हैं, और एक ट्रांस एब्डोमिनल स्कैन होता है जिसमें एब्डोमिन पे प्रोब रखते हैं. ट्रांस एब्डोमिनल स्कैन करने के लिए हमें फुल ब्लैडर रखना होता है, तब हम जो है अप्रिशिएट कर पाते हैं पेल्विक ऑर्गन्स को. या आपसे रेडियोलॉजी में ज़्यादा डिटेल्स बात करते हैं, ठीक है. And Balim, one doubt, why are we doing TVS in placenta previa, not TS? In placenta previa, first we are doing transabdominal sonography. Okay, sonologist will do, I will take for the scan, they will do transabdominal sonography, they will do first. Because पहला सिर्फ इतना पता करना है अपर सेगमेंट लोअर सेगमेंट, वो ट्रांसएब्डोमिनल से पता चल जाएगा. समटाइम्स ट्रांसवेजाइनल सोनोग्राफी में बी नीडेड, स्पेशली व्हेन दे हैव डाउट कि इज इट लो लाइंग और नॉट लो लाइंग, posterior placenta को देखने में डिफिकल्टी होती है transabdominally, then they may choose to do a transvaginal sonography when they want to see exactly कि वो cervix से कितनी दूर है, lower edge वगैरह वगैरह. So TVS is also safe. तो जनरली वो TS करते पहले ट्रांसएब्डोमिनल, फिर TVS करने की सोचते हैं अगर ज़रूरत पड़े तो, और TVS कॉन्ट्राइंडिकेटेड नहीं होता, सेफ होता है. ठीक है, चलो नाउ वील टेक अ ब्रेक फॉर 5 minutes. और ये TVS विल नॉट कॉज ब्लीडिंग इन प्लेसेंटा प्रीविया. नहीं, TVS में प्रोब वेजाइना में डालते हैं, सर्विक्स के ऊपर तक नहीं डालते हैं. ठीक है, तो वो तरीका होता है करने का जिसमें वो प्रोब को सिर्फ वेजाइना में रखते हैं. दे आर वेरी केयरफुल विद दैट, राइट. सो इट इज़ नॉट सपोज टू पोक इन टू द सर्विक्स और इनसाइड द सर्विक्स, दैट ब्लीडिंग विल बी प्रेसिपिटेटेड. गॉट इट? सो दैट्स वाई TVS इज कंसिडर्ड safe. So now we'll take a break for 5 minutes, and by 5 minutes I mean 5 minutes. Okay. Yes, guys, welcome back. And we have 50 more one-liners to go. And let me also tell you that it's more than 50 one-liners, because again, there's so many one-liners that I have taken the liberty of choosing one number and adding 2-3 one-liners in there. So we have to pick up the pace, okay? We have to pick up the pace, and let's get going. All right. So let's make the chat box active again, so that I know that you people are there still, and let's get going. Now, the cutoff for endometrial sampling in reproductive age group women. So understand here where this one-liner is coming from, okay? When we have a woman in reproductive age group presenting with abnormal uterine bleeding, you have to understand that we have to go by the Palm-Cohen system, okay? So there can be structural cause, polyp, adenomyosis, and leiomyoma, that's fibroid, and malignancy, hyperplasia, and everything. So a structural cause, okay? So ultrasound will give us an idea about that. That's why it is the investigation of choice. And then we have the Cohen group, coagulation disorders, ovulatory dysfunction, endometrial, iatrogenic, all that. Cohen group, non-structural causes, right? So ultrasound streamlines, right? And then what is important is the endometrial sampling. If you want to have a look at endometrial pathology, then we have to look at endometrial sampling. Most importantly, the suspicion of endometrial hyperplasia. That's why when the endometrial thickness is more than or equal to 12 mm, or even when the endometrial thickness may be normal, but age itself is also very important. Age of the woman more than 40 years. One always does endometrial sampling. One always does endometrial sampling. And the primary reason is, main reason is, I don't want to miss out on endometrial hyperplasia, right? Now, what is the cutoff for endometrial sampling in postmenopausal women? In postmenopausal women, the cutoff to do endometrial sampling is much less. It is 4 mm. And yeah, okay, 4 mm. So, more than 4 mm endometrial thickness, ET more than 4 mm, then we have to do endometrial sampling, right? Now, most common cause of postmenopausal bleeding in Indian women. What is that? What is that? In Indian women, not worldwide, I am asking you. Indian women. Indian women is cervical cancer. That's why per speculum examination is the first thing that I do whenever a woman comes to me with the complaint of postmenopausal bleeding, okay? Because if there is a growth on the cervix, then it can be biopsied then and there, okay? But if they ask you what is the most common uterine cause of postmenopausal bleeding, then what's the answer? Most common uterine cause of postmenopausal bleeding. So, agar cervix mein kuch nahi hai, then we focus on the uterus, and the most common uterine cause is atrophic endometritis. Atrophic endometritis. Endometrial cancer and hyperplasia are not the most common. Endometrial cancer is responsible for only 10% cases of women presenting with postmenopausal bleeding. कहने का मतलब ये है कि अगर कोई woman postmenopausal bleeding के साथ आती है, अगर यूट्रस की बात करी जाए तो यूट्रस में अट्रोफिक एंडोमेट्राइटिस मिलने के ज़्यादा चांसेस हैं, ना कि एंडोमेट्रियल कैंसर मिलने के। लेकिन इसका मतलब ये नहीं है कि हम एंडोमेट्रियल कैंसर को भूल जाएं। इसका मतलब ये नहीं है कि हम कभी एंडोमेट्रियल कैंसर के बारे में शक ही ना करें। इसीलिए तो इट इज़ इम्पॉर्टेंट टू रिमेंबर द रिस्क फैक्टर्स फॉर एंडोमेट्रियल कैंसर, जैसे कि मान लो ओल्डर एज, ओबीसिटी, राइट, डायबिटिक वुमन, राइट, और प्रोलॉन्ग्ड हिस्ट्री ऑफ एनोवुलेटरी साइकिल्स की पुरानी हिस्ट्री है, तो मेरा और शक जाएगा कि ऐसे वुमेन में एंडोमेट्रियल कैंसर निकल के आ सकता है। तो जब आ सकता है, इसलिए जब वो आपसे पूछते हैं कि इन्वेस्टिगेशन ऑफ चॉइस फॉर पोस्टमेनोपॉजल ब्लीडिंग, तो जब आपको एक चुनना होता है कि अल्ट्रासाउंड करें कि एंडोमेट्रियल सैम्पलिंग करें, तो प्रायोरिटी हो जाती है एंडोमेट्रियल सैम्पलिंग। एंडोमेट्रियल सैम्पलिंग इज द इन्वेस्टिगेशन ऑफ चॉइस फॉर पोस्टमेनोपॉजल ब्लीडिंग। और ओपीडी में करने का तरीका होता है, हम एंडोमेट्रियल एस्पिरेशन कर सकते हैं ओपीडी बेसिस पे। ओपीडी बेसिस पे वी कैन डू एंडोमेट्रियल एस्पिरेशन। फिर ऐसा भी हो सकता है कि when we have done endometrial sampling also, we've done endometrial aspiration also, and no pathology has been found, no cancer was detected, no hyperplasia was detected. अगर डिटेक्ट हो गया होता तो हम ट्रीटमेंट की तरफ चले जाते, अब नहीं हुआ डिटेक्ट और पेशेंट को फिर भी persistent symptoms है. गोल्ड स्टैंडर्ड इन्वेस्टिगेशन फॉर पोस्ट मेनोपॉजल ब्लीडिंग. क्या रह गया, क्या देखना रह गया, अब कैविटी में घुस के देखना पड़ेगा. मे बी बिकॉज व्हेन वी आर डूइंग ओपीडी बेसिस सैम्पलिंग वी आर गोइंग ब्लाइंड. सो नाउ when a woman has persistent symptoms, persistent postmenopausal bleeding, and we may have done endometrial aspiration earlier, now is the need to do gold standard sampling. So it is hysteroscopic biopsy. Excellent, Gopika. It is hysteroscopy. And not just putting the scope inside. Hysteroscopy will help us to take a directed biopsy, right? So it becomes hysteroscopic biopsy, right? Good. Now, moving on. Next set of questions. Ek second. Let me just adjust the images. Okay. First two sets. Treatment of choice for endometrial hyperplasia with atypia and without atypia. With atypia, the treatment of choice is, first one, with atypia, yes, it's a simple hysterectomy. It's a simple hysterectomy. Most of the times in clinical practice, the decision to take a hysterectomy becomes straightforward because many times the women are multiparous and they've already completed their family. Even when the women have not completed their family, it's quite possible that we may get this in a younger woman. Then also the treatment, standard treatment is simple hysterectomy only. We will counsel her about the high risk of progression to endometrial cancer. If she is having a strong desire, वो कहे कि नहीं, I cannot, I want to preserve my uterus, and she understands the risk, उसको समझ आ रही है, she's understanding the risk that there can be progression to endometrial cancer and there can be hidden endometrial cancer there, and she's willing to take that risk, then progesterone treatment can be given. Otherwise, the standard treatment is simple hysterectomy. Okay? And hyperplasia without atypia, it is always progesterone therapy. It's not estrogen therapy. It's not estrogen plus progesterone therapy. It is not oral contraceptive pills. It is progesterone therapy. Progesterone therapy can be given oral. So there are oral progesterone therapy regimens that are there, and preferably nowadays, Mirena. Preferably nowadays Mirena. ये पूछा जा चुका है आपसे recent FMGE में. Now 57, woman with intermenstrual bleeding, TVS showing feeding vessel sign. ये है feeding vessel sign. Can you see? This is the uterus. This is the hyperechoic lesion in the cavity. They may describe it like this. They may give you the image, and you can see a vessel feeding into it. This is endometrial polyp. Very good. All of you are answering. Now you've picked up your pace. Excellent. I love it. So endometrial polyp, and the next best step now is to go for a, yes, hysteroscopy. And we could go for a hysteroscopic polypectomy in the same setting. Isn't it? We could go for a hysteroscopic polypectomy in the same sitting. Right? Alright. So, symptomatic polyps. Polyps, when they are associated, polyps themselves will not be the only reason for infertility. Polyp सिर्फ अकेला कारण हो इनफर्टिलिटी का ऐसा कम ही होता है, लेकिन हाँ पॉलिप क्योंकि इतने कॉमन होते हैं इनफर्टिलिटी के पेशेंट्स में, जिनका इनफर्टिलिटी का वर्कअप चल रहा है उनमें पॉलिप्स अमूमन मिल जाते हैं. तो अगर ऐसा है कि पेशेंट सिम्टोमेटिक है, इनफर्टिलिटी के साथ है, तो जनरली हम लोग हिस्टोस्कोपिक पॉलीपेक्टमी प्रेफर कर रहे होते हैं. ठीक है. नेक्स्ट, बेस्ट डायग्नोसिस फॉर एशरमैन सिंड्रोम. एंड ट्रीटमेंट ऑफ चॉइस फॉर एशरमैन सिंड्रोम. अब यहाँ से मैं आपको 4 बातें एशरमैन सिंड्रोम के बारे में याद रखनी पड़ेंगी. एशरमैन सिंड्रोम, व्हाट हैपेंस, देयर इज यूट्राइन साइनिकिया. There's uterine synechial scarring in the endometrial cavity. Clinical context of presentation: amenorrhea, hypomenorrhea. Maybe she has scanty period, she's trying to conceive, whatever. She may have come with amenorrhea. Hormone profile is absolutely normal. Hormone profile is absolutely normal. So this is a recall of the clinical profile also. Maybe maybe she may have come with infertility. She may have come with infertility. We may have done HSG. So we can see filling defects in HSG. HSG may be able to pick up uterine synechial, but we can't be sure. So the best diagnosis of Asherman syndrome in any clinical context, that is why I gave you 2 clinical context in a nutshell, right? So best for diagnosis of Asherman syndrome is going to be hysteroscopy, and the treatment of choice is hysteroscopic adhesiolysis. Okay, very good, fine. And the reason why Asherman syndrome develops, the history of curettage is very, very important. History of curettage could be the clue in the question, and not any curettage, very rigorous curettage. Rigorous curettage in the sense that curating the basal layer of the endometrium, because it's the basal layer of the endometrium which regenerates each month. Now we have curated and destroyed and damaged the basal layer of the endometrium. So whenever we do curettage in postpartum settings, मतलब किसी को आ रहा है कोई postpartum bleeding, post abortal, वहाँ उस setting में जब हम curettage करते हैं, then more likely chance that we may damage the basalis layer of the endometrium. And heat, I may be getting your name wrong, followed by pediatric Foley's for 14 days. Excellent. The point is, when we do adhesiolysis, uterus, okay, when we do adhesiolysis, we have to keep the 2 walls of the uterus apart. हमने adhesiolysis किया, ये ऐसे collapse हो जाएगा, फिर से adhesions बन जाएंगे. So you have to keep them separate. How do we do that? We can do pediatric Foley's insertion. अंदर pediatric Foley's रख दो, या फिर intrauterine device, T-shaped intrauterine device रख दो अंदर, after removing the copper wire. आफ्टर रिमूविंग द कॉपर वायर. तो कहने का मतलब ये है कि एडिसियोलिसिस किया और यहाँ पे या तो पीडियाट्रिक फोलीज रख दिया या फिर ये टी शेप डिवाइस रख दी, लेकिन कॉपर टी हटाया, वो कॉपर टी वायर, जो वायर है कॉपर की, वो हटा दी. एंड अब तुम एक और बात इसमें ऐड कर लो, फिर साथ में एंडोमेट्रियल लाइनिंग को बिल्डअप करने के लिए ईस्ट्रोजन थेरेपी भी देनी पड़ेगी. अभी तो हमने एडियोलिसिस कर दिया, अब एंडोमेट्रियम को प्रोलिफरेट करवाना है. वी हैव टू बिल्ड अप द एंडोमेट्रियल लाइनिंग. सो फॉर दैट सम लॉन्ग ड्यूरेशन हाई डोज ईस्ट्रोजन थेरेपी इज यूजुअली रिक्वायर्ड. प्रोजेस्टेरॉन बाद में फिजियोलॉजिकल करेंगे ना, पहले ईस्ट्रोजन से बिल्डअप करेंगे, कुछ एंडोमेट्रियल लाइनिंग, सम एंडोमेट्रियल लाइनिंग विल बिल्ड अप, देन वी विल ऐड प्रोजेस्टेरॉन लेटर. So it has to be high dose estrogen therapy alone initially. Okay, fine. Chalo, next set. Woman with heavy menstrual bleeding plus dysmenorrhea, uniformly enlarged tender uterus, myometrial cysts on transvaginal sonography. What is the diagnosis and what is the usual treatment? There are 2 classic images. So you can see here that there is thickening of the myometrium. There is thickening of the myometrium. Usually the posterior wall is thickened more than the anterior wall. So this is the posterior wall, the myometrium that is thickened. We can see some myometrial cysts also, just dark round opacities, right? And we can see this, can you appreciate the Venetian blind appearance? जो पर्दों में blind लगी रहती है, blind, that is called as the Venetian blind appearance. Right? So these are few things I want to appreciate. I want you to people to appreciate. इस image में diagnosis is adenomyosis, excellent, and the usual treatment of choice. See, मैंने शब्द का प्रयोग किया है, मैंने use किया है word usual, because generally women are multiparous. Generally women have already completed their families. So the decision of taking a hysterectomy, doing a hysterectomy, simple hysterectomy, is easy. But nowadays, we can find younger women with adenomyosis. We can find nulliparous women with adenomyosis, and then hysterectomy is not an option for them. Then conservative progesterone therapy can be tried. Otherwise, for you people, remember, mostly your women are going to be multiparous, family completed. The decision for hysterectomy is much straightforward. Now, if there are asymptomatic fibroids, any treatment needs to be done. Any treatment needs to be done in asymptomatic fibroids. Yes. It doesn't matter what is the size of the fibroid. Okay. If the fibroid is asymptomatic, then conservative, just expectant management. We can follow up with a repeat scan to see if the fibroid is growing in size or anything, or follow up to see if the woman is developing any new symptoms. But as long as it is asymptomatic, no treatment is needed. Okay, no treatment is needed. Size का criteria पहले होता था. It used to be an older thing where criteria of size was there. Size is not an absolute criteria. Okay. Now, submucosal fibroids, if there are submucosal fibroids like you can see in this image. If there is a submucosal fibroid like you can see in this image causing infertility or heavy menstrual bleeding, what is the treatment of choice? It is surgical treatment which is preferable, and here it will be hysteroscopic myomectomy. Hysteroscopic myomectomy for submucosal fibroid, not for every submucosal fibroid. Type 0 and type 1. Figo type 0 and Figo type 1, which are protruding more into the uterine cavity and less of it is in the uterine cavity, in the myometrium. Try to remember it like that. For now, just mug up type 0, type 1. It is hysteroscopic myomectomy. Okay. Fine. All right. And subserosal, see, I was waiting somebody. If it is subserosal, if it is intramural, depending upon the surgeon's expertise, depending upon the availability, depending upon the technicalities, it can be laparoscopic, it can be abdominal. Wherever possible, it will be laparoscopic. Wherever possible, wherever feasible, minimally invasive will be done, isn't it? राइट सो वो एब्डोमेन में कैसे घुसना है वो अलग बात है ना. मतलब अभी वो एब्डोमेन में एब्डोमिनल मायोमेक्टमी ऐसे करनी है कि भाई वी हैव टू डू एन ओपन surgery, or we can go laparoscopic myomectomy we can do. So it will depend upon a lot of factors, surgeon's expertise, feasibility. Wherever feasible, it doesn't matter whether it is intramural, whether it is subserosal. It mainly matters on the surgeon's expertise, feasibility, availability. Okay, fine. And hysterectomy for fibroid, अब ये वन लाइनर में था नहीं बट अब बता देती हूँ मैं. हिस्टेरेक्टमी फॉर अ वुमन विथ फाइब्रॉइड इज जनरली डन if she wants a definitive treatment of her symptoms, she is more than 40 years old and her family is completed, then it can be offered. उसमें भी रूटीन नहीं है. ओके, उसमें भी रूटीन नहीं है. ठीक है. और if it is a post menopausal woman with a rapidly growing fibroid, then हम सिर्फ कोई स्कैन देख के नहीं बोल सकते कि ये लियोमायोसार्कोमा का डाउट होता है जो सिर्फ हिस्टोपैथ पे पता चलता है. देन हिस्टेरेक्टमी. दीज आर टू वैलिड इंडिकेशंस फॉर हिस्टेरेक्टमी. ओके. एंड जय, adenomyosis with AUB, ये तो कर तो दिया. adenomyosis with heavy menstrual bleeding, dysmenorrhea, usual treatment simple hysterectomy. But if she is not willing for a hysterectomy, for whatever reason hysterectomy cannot be done, then progesterone therapy is there. Okay. All right. Next set of questions. Drug of choice for active management of third stage of labor. First line uterotonic for treatment of PPH. Best uterotonic for treatment of PPPH. This is the first set. एंड मैं कुछ ऑप्शंस में देख रही हूँ. मिरीना, हाँ, जो प्रोजेस्ट्रॉन थेरेपी है वो मिरीना के फॉर्म में हो सकती है, एडिनोमायोसिस में भी. यस. कौन पूछ रहा था, कौन बता रहा था? ड्रग ऑफ चॉइस. यू वर ओनली सेइंग. सो यस वो मिरीना हो सकता है. सो ड्रग ऑफ चॉइस फॉर AMTSL एक्सीलेंट ऑक्सीटोसिन. Dose you have to remember 10 units intramuscular as recommended by Government of India. It should never be given IV bolus. Never give IV bolus, can cause sudden hypotension, even dangerous tachycardia, can precipitate MI also. First line uterotonic for treatment of PPH, oxytocin. This here is given by IV infusion. Here is given by IV infusion. And best uterotonic for treatment of PPH, yes. If, see, generally I'm not a very big fan personally of such kind of one-liner questions, but they have been asked. See, we use whatever drugs we have available, right? So oxytocin we can try, methergin, we have this whole list of contraindications for methergin also, right? The context is that let's say for example there's a woman who's having PPH, okay? We've given oxytocin, okay? If she's a candidate for methergin, if there are no contraindication for methergin, we may have given methergin also. If it is not working, what is the best drug? Okay, and I have to choose between misoprostol and carboprost. Clinics में मैं misoprost भी यूज करूंगी, मैं carboprost जो मेरे पास है मैं वो यूज करूंगी. एग्जाम में आपसे पूछे बेस्ट ड्रग, तो जवाब है कार्बोप्रोस्ट. लॉजिक है, अगर किसी को हमने ऑक्सीटोसिन दे दिया है, उसके ऊपर से मिसोप्रोस्टोल देने का बहुत ज्यादा फायदा नहीं होता है, रिसर्च ये कहती है. इसलिए बेस्ट यूट्रोटोनिक फॉर ट्रीटमेंट ऑफ पीपीएच जवाब है कार्बोप्रोस्ट. वो आपसे डोज पे भी पूछ चुके हैं सवाल. मैक्सिमम डोज बताओ. PGF2 अल्फा, कार्बोप्रोस्ट इज PGF2 अल्फा. PGE2 is not recommended for AMTSL. It is not recommended for treatment of PPH as per WHO. वेस्ट में आते हैं इंजेक्टेबल फॉर्म्स ऑफ PGE2 भी. हमारे पास आता है लेबर रूम में जेल फॉर्म ऑफ PGE2, डाइनोप्रोस्टोन, जिसको हम इंडक्शन ऑफ लेबर और सर्वाइकल राइपनिंग के लिए यूज करते हैं. हमारे पास आता ही नहीं है इंजेक्टेबल PGE2. ठीक है, तो PGE2 is not recommended for AMTSL and treatment of PPH, and like you said, it is 2 milligrams. Yes, 2 milligrams. So basically 250 micrograms every 15 minutes for maximum of 8 doses. IM देना है कार्बोप्रोस्ट को. Carboprost is given intramuscularly, not IV, never IV. You may have seen it being given intramyometrially भी देते हैं, लेकिन IV कभी भी नहीं देते. ओरल में तो ये आता नहीं है, इंजेक्टेबल ही है ये IM. ठीक है, इसके अलावा एक और ड्रग है विच इज कार्बिटोसिन. एक और ड्रग है विच इज कार्बिटोसिन. Carbitocin is a long-acting synthetic oxytocin analog which is recommended for AMTSL. AMTSL में recommended है, लेकिन treatment of PPH के लिए नहीं है. Not for treatment of PPH. Not for treatment of PPH. तो ये एक extra point हुआ. ठीक है, and then अब मुझे हटाना पड़ेगा. Less clutter in the slide. And yes, 100 microgram slow IV. 100 microgram is the dose. Slow IV over 10 minutes भी दे सकते हैं, उसको इन्फ्यूजन में करके इन्फ्यूजन में भी दे सकते हैं. 100 microgram is the dose. Next, drug of choice for first trimester MTP, drug of choice for second trimester MTP. Same है, डोज फर्क है. Okay, so it is mifepristone 200 milligram oral plus misoprostol PGE1 800 microgram. अब ये 800 माइक्रोग्राम मीजोप्रोस्टोल है, वो सबलिंगुअल भी दे सकते हैं, ओरली भी दे सकते हैं, बकल भी दे सकते हैं, परवेजाइनल भी दे सकते हैं. जनरली जब हमें किसी को बोलना होता है कि घर पे खाए तो हम उसको सबलिंगुअल जनरली रेकमेंड करते हैं मोस्ट ऑफ द टाइम्स. ठीक है, और ड्रग ऑफ चॉइस फॉर सेकेंड ट्राइमेस्टर MTP यही है, मिफेप्रेस्टोन 200 मिलीग्राम ओरल प्लस मीजोप्रोस्टोल, यहाँ पे डोज है 400 माइक्रोग्राम, 400 माइक्रोग्राम एवरी 3 आवर्स। हमारा अपना है इंडिया में, है ना, ऐसे कोई हार्ड एंड फास्ट नहीं है कि इतनी मैक्सिमम डोजेस होने चाहिए, बट हम लोग मान के चलते हैं मैक्सिमम 5 डोजेस इन 24 आवर्स मीजोप्रोस्टोल की फॉर सेकेंड ट्राइमेस्टर एमटीपी। अब अगर आपसे पूछे सेकेंड ट्राइमेस्टर एमटीपी के लिए, राइट, ड्रग ऑफ चॉइस पूछे और अलग अलग करके ऑप्शन दे दे, मीफेप्रेस्टोन ऑप्शन ए, मीजोप्रोस्टोल, ऑक्सीटोसिन, एथाक्रिडिन लैक्टेट, दिस एंड दैट, व्हाटएवर, right? So if separately it is given, so mifepristone alone is not treatment. Mifepristone alone is not drug of choice. So if you have to pick one, then pick misoprostol as the answer. Then pick misoprostol as the answer. If you have to pick one, if both are given in the option together, that is the drug of choice. So that is, let's say, the regimen of choice. But if you have to pick one drug, then it is misoprostol. Alone it can be given. ठीक है, चलो next set of question. Drug of choice for prevention of preeclampsia and drug of choice for hypertension in preeclampsia and drug of choice for eclampsia. Yes. Belim minimum age for MTP, आपका INI-CT पे क्वेश्चन आया था, आई नो। जब तक आप लोग चैट बॉक्स में आंसर लिख रहे हो ये दे लेते हैं। मिनिमम एज फॉर एमटीपी, देखो एज सच कोई मिनिमम एज है नहीं लीगली, देयर इज नो लीगल, जो एक्ट में, एमटीपी एक्ट में ऐसा कुछ नहीं लिखा है कि इससे एज में कम में नहीं कर सकते। हम लोग माइनर में कर सकते हैं, लेस देन 18 ईयर्स में कर सकते हैं, लेकिन फिर पेशेंट खुद अपना कंसेंट नहीं दे सकता वैलिड, फिर गार्जियन का कंसेंट चाहिए होता है। दैट इज द लीगल रिक्वायरमेंट। So when they had asked blanket question, then I think they wanted to, best answer would have been 18 years. Because 18 years में a person can give a valid consent on her own. Because at the end of the day, consent तो patient की ही important है ना, तो इसलिए फिर minimum age में उस question का जवाब I think best answer होता 18 years. Alright, so we have got the answers now. So when we say drug of choice for prevention of preeclampsia, so meaning high risk women में दे रहे हैं, then it is aspirin, aspirin, low dose aspirin. Okay, now drug of choice for hypertension in pregnancy, it is labetalol. Okay, so when we want to give for chronic control, it is oral labetalol. When we have acute hypertensive crisis, then we can give IV labetalol also. IV labetalol for acute hypertensive crisis हम मैक्सिमम एक गो में 220 मिलीग्राम दे सकते हैं। 220 मिलीग्राम का मतलब ये नहीं कि साथ में दे दी, हम देते हैं 20 पहले देते हैं, फिर 15 मिनट बाद देन वी अगेन चेक द बीपी, देन वी कैन गिव 15 minutes, we can give 20, 40, 80 milligram, like that we give. So it is labetalol. The important thing is that nifedipine is also first line. Nifedipine is also first line. It is always oral nifedipine. It is never sublingual nifedipine. It is never sublingual nifedipine. Right? Other drugs are also there. Hydralazine is there. Methyl dopa is there. Please remember that ACE inhibitors, angiotensin receptor blockers, other beta blockers, they are contraindicated. Other beta blockers, they are contraindicated. Please remember labetalol is contraindicated in asthma and bradycardia. So this is how they integrate, gynae and pharmacology. Okay, so labetalol will have its own contraindication. It is contraindicated in asthma and it is contraindicated in women who have bradycardia. So please remember ACE inhibitors, angiotensin receptor blockers, they are contraindicated. And diuretics can be used. Diuretics can be used for treatment of pulmonary edema. For treatment of pulmonary edema, diuretics can be used. Now, drug of choice for eclampsia is magnesium sulfate. Yes, magnesium sulfate. Why? Because it is going to prevent convulsions. It is going to help prevent and decrease the incidence of convulsions. है ना। तो मैग्नीशियम सल्फेट जो है वो नेसेसरी नहीं होता है कि हम जो है उसको दें तो अभी कन्वर्जन को वो स्टॉप कर देगा। कन्वर्जन तो एक्लेम्शिया का कन्वर्जन वैसे भी सेल्फ लिमिटिंग होता है, लेकिन एक बार कन्वर्जन हो गया तो पेशेंट को बार बार कन्वर्जन आ सकते हैं। सो दैट इज व्हाई ड्रग ऑफ चॉइस इज मैग्नीशियम सल्फेट। इफ दे आस्क यू व्हाट इज द डेफिनेटिव ट्रीटमेंट फॉर एक्लेम्शिया, definitive treatment for eclampsia, yes, termination of pregnancy. So you have to do all these things. You have to do all these things in the sense that you have to give magnesium sulfate. ABC, do not forget airway breathing circulation in a patient with who's having active convulsions. Airway protection is very important. That is true for anybody who's having convulsions, right? And apart from that, the definitive treatment is delivery. Delivery or termination of pregnancy. Vaginal delivery can be attempted most of the times. Most of the times it is possible to have a vaginal delivery. We can augment labor, we can induce labor. Cesarean section is for obstetric indications. Many times, mostly it is possible to achieve a vaginal delivery. And then you'll additionally, obviously you'll give, if that is a preterm patient, then you will give steroid cover also. But once convulsion has happened, you have to deliver. Irrespective of period of gestation, there are few indications where you have to deliver irrespective of period of gestation. So, sorry, impending eclampsia. A woman with severe preeclampsia presenting with headache, blurring of vision, epigastric pain. Signs and symptoms of impending eclampsia are there, right? HELP syndrome is there. Okay, then obviously, then you will not wait for convulsion to happen. Now, then you have to deliver irrespective of period of gestation. Yes, Mahendra, meso micrograms में ही है, meso micrograms में ही है. Okay, and Dr. Ved, AF, acute fatty liver of pregnancy, also delivery is the definitive management. Right. Ab first sign of magnesium toxicity. First sign of magnesium toxicity. In severe preeclampsia, DOC, drug of choice, severe preeclampsia may, it will depend upon the period of gestation. It will depend upon the period of gestation. If a woman has severe preeclampsia, she is already more than 34 weeks, deliver. If she is severe preeclampsia, she is less than 34 weeks, focus on stabilization, controlling BP, steroid cover and everything and assessment, and daily we have to reassess the situation. If there is mild preeclampsia, no severe symptoms, we can take the pregnancy till 37 weeks. Once 37 weeks have reached, then we deliver. Okay. The first sign of magnesium sulfate toxicity, yes, loss of knee jerk. Loss of knee jerk, loss of deep tendon reflexes, very good. So, we have to monitor three things. We have to monitor knee jerk. If knee jerk is absent, we will omit the dose. Right? We will omit the dose of magnesium sulfate. We are talking about maintenance dose. Please confuse मत होना. Loading dose हमेशा देते हैं, जब भी इंडिकेशन बनेगा लोडिंग डोज देने में कोई मनाही नहीं है। ये जो मॉनिटरिंग चल रही है, मॉनिटरिंग कैसे कर रहे हैं? नी जर्क मॉनिटर कर रहे हैं, रेस्पिरेटरी रेट, यूरिन आउटपुट मॉनिटर कर रहे हैं, ये मेंटेनेंस डोजिंग के लिए मॉनिटर कर रहे हैं। इफ नी जर्क इज एब्सेंट, वी स्टॉप फर्दर डोजिंग। रेस्पिरेटरी रेट, respiratory depression is a toxicity. So, if respiratory rate is less than 16 per minute, respiratory rate less than 16 per minute, I get alerted. I will not give the dose. Okay. Urine output adequate होना चाहिए. Magnesium sulfate does not decrease urine output. Magnesium sulfate is excreted in the urine. In women with preeclampsia, eclampsia, renal pathology also is there. They can have oliguria because of their pathology and they can have decreased urine output. and then magnesium sulfate toxicity can be precipitated. So urine output अगर less than 100 ml in 4 hours या less than 30 ml per hour है, then we have to stop further dosing. ओके फर्दर डोजिंग करने के लिए फिर हमें सीरम मैग्नीशियम लेवल्स देखने पड़ेंगे अगर करनी है तो आपको इतना पता होना चाहिए कि लॉस ऑफ नी जर्क हुआ, रेस्पिरेटरी रेट लेस देन 16 बीट्स पर मिनट हुआ तो यू गेट अलर्ट, यूरिन आउटपुट कम हुआ यू गेट अलर्ट, स्टॉप फर्दर डोजिंग. ठीक, फाइन. नेक्स्ट सेट ऑफ वन लाइनर्स. डायग्नोसिस ऑफ प्रीटर्म लेबर. Diagnosis of preterm labor needs regular contractions and cervical dilatation of at least initial presentation में cervical dilatation कितना होना चाहिए. एंड आप लोग ना जब खुद पॉइंट ऐड करते हो ना तो इट जस्ट एड्स टू द लेक्चर, एक्चुअली इट्स एड्स टू द डिस्कशन. सो लाइक वेद ने सही बोला, एंटीडोट है कैल्शियम ग्लूकोनेट. तो अब अगर रेस्पिरेटरी डिप्रेशन हो ही गया है, आपने डोजिंग भी स्टॉप कर दी, बट रेस्पिरेशन डिप्रेशन सेट इन हो चुका है तो आपको एंटीडेट देना पड़ेगा, तो कैल्शियम ग्लूकोनेट है. बट सिर्फ नी जर्क एब्सेंट है, बाकी पेशेंट पूरा ठीक है, तो कैल्शियम ग्लूकोनेट थोड़ी दे देंगे, तब वो स्टॉप से काम चल जाएगा. गेटिंग माई पॉइंट, राइट? सो एंटीडोट इज कैल्शियम ग्लूकोनेट. इफ नीडेड इट कैन बी गिवन. मोस्ट ऑफ द टाइम्स इट विल बी नीडेड व्हेन रेस्पिरेटरी डिप्रेशन इज ऑलरेडी सेट इन. Okay, so cervical dilatation of at least 2 centimeters at initial presentation. Okay, obviously we want to have, progressive cervical dilatation and effacement. That is how labor is diagnosed at term. That is how labor is diagnosed preterm also. Cervical dilatation of at least 2 centimeter at initial presentation होना चाहिए. If no cervical changes, तो क्या कर सकते हैं? If no cervical changes, तो क्या कर सकते हैं? Then we can check for fetal fibronectin in cervicovaginal secretions. This can be checked between 23 to 34 weeks. If no cervical changes, we can see transvaginal sonography, cervical length less than 20 mm to help diagnose preterm labor. ठीक है, अब ये फीटल फाइब्रोनेक्टिन, ट्रांसवेजाइनल सोनोग्राफी, सर्वाइकल लेंथ क्लिनिकल प्रैक्टिस में बहुत ज़्यादा हम लोग यूज़ करते नहीं हैं, हम पेशेंट को एडमिट करके ऑब्जर्व करते हैं. ठीक है, अगली बात, ड्रग ऑफ चॉइस फॉर टोकोलिसिस इन प्रीटर्म लेबर. ड्रग ऑफ चॉइस फॉर टोकोलिसिस इन प्रीटर्म लेबर. यस, व्हाट इज द ड्रग ऑफ चॉइस? हमारे यहाँ ड्रग ऑफ चॉइस क्या, हम क्या यूज कर रहे हैं? आप आंसर करेंगे निफेडेपिन. ओके, फाइन. कैल्शियम चैनल ब्लॉकर, निफेडेपिन इज अ कैल्शियम चैनल ब्लॉकर, हमें ये भी पता है. चलो, इसके बाद नेक्स्ट, एंटीनेटल कॉर्टिकोस्टेरॉइड कब देने हैं? एंटीनेटल कॉर्टिकोस्टेरॉइड कब देने होते हैं? गिवन इफ लेस देन 34 वीक्स, लेस देन 34 वीक्स विद स्टैब्लिश्ड प्रीटर्म लेबर और इंडिकेटेड प्रीटर्म बर्थ. मान लो हम ही चाह रहे हैं पेशेंट को कि भाई हम इंड्यूस कर रहे हैं किसी को प्रीटर्म, तमाम इंडिकेशन हो सकती है, हाइपरटेंसिव हो सकती है, प्री एक्लेम्शिया हो सकती है, हम इंडक्शन कर रहे हैं, तो इंडिकेटेड प्रीटर्म बर्थ अगर हम करवा रहे हैं तो भी उससे पहले स्टेरॉइड कवर बनता है. वो आपसे पूछेंगे ड्रग ऑफ चॉइस क्या है? ड्रग ऑफ चॉइस क्या है? व्हाट इज द ड्रग ऑफ चॉइस फॉर अस? इट इज डेक्सामिथासोन. Both dexamethasone and betamethasone, both are equally good. कोई फर्क नहीं, both are equally efficacious as far as causing pulmonary maturity is concerned. So both are equally efficacious, but for us, if you have to pick one, drug of choice is dexamethasone. In the government supply, it is available, it is free of cost, and it is the drug of choice, period. Okay, and the dose you have to remember. Very, very important. What is the dose? Very good. 6 milligram 12 hourly intramuscular for 4 doses. Role of magnesium sulfate in extreme prematurity. Role of magnesium sulfate only in extreme prematurity. Different guidelines, different places it's written differently. It is usually less than 30 to 32 weeks. Role of magnesium sulfate, very good. Neuroprotection. Neuroprotection for the fetus. Neuroprotection for the fetus. And yes, beta methasone. देखो बीटा मिथासोन ऐसे याद कर लो, वेरी गुड. 12 मिलीग्राम देना, उतना ही टोटल देना है, 12 मिलीग्राम 24 आवर्स अपार्ट. IM for 2 doses. IM for 2 doses. टोटल उतना ही देना है. जब 12 दे देते हैं तो 24 आवर्स अपार्ट कर देते हैं और फिर लगती सिर्फ 2 डोजेस है 4 की जगह. प्रिडिक्शन ऑफ प्रीटर्म बर्थ इन हाई रिस्क वुमेन. अब देखो सिचुएशन बिल्कुल डिफरेंट है. प्रिडिक्शन ऑफ प्रीटर्म बर्थ हो रहा है, पेशेंट को कॉन्ट्रैक्शन नहीं है, patient is not having contractions, patient is not symptomatic. I am not diagnosing preterm labor right now. I am diagnosing a patient, maybe she is high risk. What sort of high risk she is? She is high risk because she has a history of, in the past she had a history of spontaneous preterm birth. She is high risk because she has a history of recurrent second trimester miscarriage, whatever. So in this current pregnancy, is there, can I predict preterm birth? Only in high risk women. No utility in every woman or in low risk woman. Cervical length is measured on transvaginal sonography. What is the cutoff? They have asked you in exams. The cutoff is less than 25 mm between 16 to 24 weeks is predictive of preterm birth or the risk of going into preterm birth. Right? Now, the drug of choice for prevention of preterm birth. The drug of choice for prevention of preterm birth is progesterone. Okay? Progesterone. As far as drug is concerned. Okay? Cerclage is generally done when there is more than or equal to 3 recurrent preterm births, or less than 3 recurrent preterm births plus short cervical length. So the criteria is different. Okay, but the drug of choice is progesterone. Progesterone is not a tocolytic. Please remember, progesterone is not a tocolytic. Okay. Or progesterone drug is not used as a tocolytic drug. Now, next set of MCQs. Investigation of choice for antepartum hemorrhage. Context. Patient presents with antepartum hemorrhage, so she is in the late, she is beyond 24 weeks. आपको generally clinical profile में दिया जाएगा some woman in her 3rd trimester. Okay. Now, whenever there is antepartum hemorrhage, it could be placenta previa, it could be placental abruption. First priority is obviously you have to do the examination also, but if you have to pick an investigation, it is going to be ultrasound, because we want to go for localization of placenta, right? We want to rule out previa, है ना? Rule out करेंगे previa. That is important, right? So investigation of choice is ultrasound. ब्रेक पे जाने से पहले ये ऑलरेडी डिस्कस हो चुका है कि ट्रांस एब्डोमिनल सोनोग्राफी जनरली पहले करते हैं, एंड TVS if needed is also safe. TVS if needed is also safe. What is the most dangerous type of placental abruption? Most common type of abruption is basically mixed type. So some of the abruption is, some of the blood loss is concealed, hidden behind the placenta, some is revealed. So most commonly it is mixed type. But most dangerous type is the concealed type. Most dangerous type is the concealed type. Why? Because the risk of DIC. Because the risk of DIC is there. Risk of DIC is more. Okay. In entire obstetrics, the most common cause of DIC is placental abruption. Remember that also, और ये ultrasound तो लिख ही लिया था हमने. Now, what is the clinical classification of severity of placental abruption? Clinical classification of severity of placental abruption is the Page classification. Page classification. Okay. Now, okay. Now you need to have a basic understanding of this page classification. ठीक है, एक ही लाइन में कॉन्सेप्ट बता देती हूँ मैं. When the placenta separates, it is maternal bleeding that is happening. Blood that may be collecting behind the placenta, blood that may be coming out, and obvious. Right? Now depending upon how much placenta is separated, थोड़ा सा placenta separate हुआ है, बहुत ज़्यादा placenta separate हो गया है, उसके हिसाब से clinical presentation होगी कि नहीं होगी. तो अगर थोड़ा सा ही placenta separate हुआ है, some mild degree of placental separation is there, then there is some bleeding, and the fetal heart rate would be normal, patient would be stable, mother would be stable. But as more and more placenta separates, severity बढ़ गई, then the link between the mother and the fetus is the placenta. So if more placenta is separated, what about the gaseous exchange? How is the fetus getting oxygen? It is not getting oxygen. So more the placenta separates, more is the maternal blood loss, more is the chance of fetal distress. Okay, fine. And by the time a baby is dead, let's say that there is a dead baby. Let's say that there is a woman with placental abruption with dead baby, and unstable woman. क्या मतलब हुआ? अगर मेरे को ऐसा सिचुएशन मिले, आई एम श्योर कम से कम 25 ml ब्लड लॉस हो गया होगा, कम से कम मोर देन 50% प्लेसेंटा सेपरेट हो गया होगा, तब जाके it will result in an unstable woman in a dead baby. So if I have a placental abruption case with an unstable woman with a dead baby, it is massive. Much of blood loss may have happened. और ये जो blood loss है 2500 ml वाला, हो सकता है सारा का सारा visible हो सकता है छुपा हुआ भी हो concealed में. And that is why you are saying right that there is tense and tender uterus, painful bleeding, right? Tense, tender uterus, uterine tone increase. These are your clues, clinical clues. अभी हम clinical तो discussion कर नहीं रहे, one liner कर रहे हैं, लेकिन फिर भी अब आपने बात छेड़ दिया तो yes, tense, tender uterus, painful bleeding, and on top of that, hemodynamic instability can come, distress may happen, fetal distress may happen, baby may die, right? And vaginal delivery is possible. Vaginal delivery is possible. Management, I'll just delete this. One liner I want to give you. Management, resuscitation and delivery. Many times vaginal delivery is possible. As much as we try, we should try to do vaginal delivery. Cesarean section is for obstetric indication. ठीक है, so delivery has to be vaginal. अब जैसे फॉर एग्जाम्पल अभी बताया था मैंने, अब्रप्शन, मदर अनस्टेबल, बेबी डेड. Why will you do a cesarean section? You will do resuscitation and try for vaginal delivery. Yes, of course, if there is fetal distress, with placental abruption, then I want to go for cesarean section for the sake of the fetus. Okay. And like you said, how do we manage DIC? DIC, correction of DIC, resuscitation, FFPs, cryoprecipitates, correction of DIC, and preferably vaginal delivery. And cesarean section is for obstetric indication. Obstetric indication का मतलब कि vaginal कर ही नहीं सकते, possible नहीं है vaginal करना, तब cesarean करेंगे. ठीक है. Next set of questions. Yes, mode of delivery for placenta previa and low-lying placenta. So you have a patient with placenta previa. Okay, let's say at term or in labor or active bleeding or unstable, whatever. Mode of delivery for placenta previa. टर्म है प्लेसेंटा प्रीविया, लेबर में चली गई प्लेसेंटा प्रीविया के साथ, एक्टिव ब्लीडिंग चालू है प्लेसेंटा प्रीविया के साथ, या फिर अनस्टेबल है प्लेसेंटा प्रीविया के साथ, राइट, ब्लीडिंग प्लेसेंटा प्रीविया के साथ, लो लाइंग प्लेसेंटा यानी कि प्लेसेंटल एज विद इन 2 सेंटीमीटर्स ऑफ इंटरनल ऑस, प्लेसेंटल एज विद इन 2 सेंटीमीटर्स ऑफ इंटरनल ऑस. सो यू हैव डन an urgent ultrasound. Okay, an urgent ultrasound has to be done priority, and obviously resuscitation. ये भूल नहीं जाना resuscitation. In a bleeding patient, please don't forget resuscitation. But if it is placenta previa partially totally covering os, or even if it is a low lying placenta, it is always cesarean section. It is always cesarean section, and obviously do not forget resuscitation. Conservative management for placenta previa is called as McAfee and Johnson's protocol. Is called as McAfee and Johnson protocol, where the patient is admitted in the ward under observation, vital charting is done, blood is arranged, steroid cover is given, all that. Okay. So conservative management is only and only done when the patient is not in labor, there is no active bleeding, patient has to be stable, it has to be a viable and healthy fetus. Viable and healthy fetus. Logic एक ही है. Conservative management of placenta previa एक ही कारण के लिए किया जा रहा है, for the baby's sake. So if the baby is viable, if the baby is preterm, then only we think of doing conservative management for placenta previa, provided बशर्ते woman is not in labor, no active bleeding and stable. क्योंकि बेबी को बचाने के चक्कर में यहाँ पे मदर की लाइफ को सैक्रिफाइस नहीं किया जा सकता. That is the logic. Okay, and this is the one liner. Okay, and like you said, Suhasini, PS and PV, yes. In a patient with antepartum hemorrhage, do not do PS and PV. First, we are going to rule out previa. Once the previa is ruled out, once placenta is in the upper segment, you know it is not placenta previa, then we can proceed with PS and PV. Okay, with previa cases, we do not go for with placenta previa cases, we don't want to do PS and PV. Okay, next set of one-liners. Most common HPV type associated with CIN and cervical cancer. Fatafat, CIN cervical cancer, HPV 16 and 18. If you have to pick one, then HPV 16 is the answer. Target age group for HPV vaccination. Target age group is 11 to 14 years of age. इसको और विंडो को और कम करना है तो 11 to 12 years of age. Recommended है कि हम 9 से 26 years we can give. Between 9 to 26 years we can give. Target is 11. This is priority age group for HPV vaccination. Beyond 14 years up till 26 years, catch-up vaccination is done. So priority or target age group is 11 to 14 years. Beyond 26 years up till the age of 45, it is generally not recommended, but only in very high risk women, case to case basis, one may choose to give. Yes, males can also be given the vaccine, but it is currently in India, it is not being routinely followed. Right, now you are right, the dosage is when she is less than 14 years, then we go for the 2 doses. And more than or equal to 14 years, then we have to give 3 doses. Okay. Right. Now, priority age group for cervical cancer screening. Now, this priority age group is according to WHO. This priority age group is according to the Indian guidelines. ठीक है, तो हम लोग के यहाँ priority age group है 30 to 49 years of age. HPV DNA testing can only be done in women who are more than 30 years of age. So concept is that if I have to screen somebody who is less than 30, HPV DNA testing is not an option. HPV DNA टेस्टिंग और को टेस्टिंग क्या होती है, एक ही पेशेंट में HPV भी करें और पैप्समेयर भी करें, दैट इज कॉल्ड एज को टेस्टिंग, राइट. तो HPV DNA टेस्टिंग और को टेस्टिंग रिपीट एवरी 5 year. PAP alone, cytology alone, repeat every 3 years, and if via, repeat every 3 years. ठीक है. अब एक और सवाल बड़ा फेवरेट रहता है कि लो रिसोर्स सेटिंग में क्या करें. लो रिसोर्स सेटिंग में इट इज आइदर वाया विजुअल इंस्पेक्शन विद एसिटिक एसिड और HPV DNA टेस्टिंग. HPV DNA टेस्टिंग. कैसे HPV DNA टेस्टिंग लो रिसोर्स सेटिंग में, अब आजकल आ रहे हैं, अवेलेबल हो रहे हैं लो कॉस्ट HPV टेस्टिंग किट्स, राइट. सो दे कैन बी यूज्ड वेरेवर दे आर अवेलेबल, राइट. दैट इज वाई इन लो रिसोर्स सेटिंग HPV DNA टेस्टिंग इज ऑल्सो पॉसिबिलिटी, किट बेस्ड टेस्ट होता है उसमें, राइट. एंड cytology however is resource intensive. Cytology however is for high resource setting only. So both are fine, okay. Now abnormal screening test, what do we perform? If abnormal screening test is there, what do we perform? Next step, if abnormal screening, what is the next step? Next step is colposcopy. Next step is colposcopy directed biopsy. Colposcopy directed biopsy, okay, fine. And treatment of choice for high grade CIN. High grade CIN meaning CIN 2 or 3. If they ask you CIN 2 or 3 high grade CIN, they may say treatment of choice for high SIL. They may say this also in the question. Answer is LEAP. Answer is LEAP. Okay. Now next one liner, treatment of choice for cervical cancer stage 2B and beyond and bulky growths. Stage 2B मतलब parametrium involved. Once parametrium is involved, parametrium involved. Bulky growths मतलब it may be limited to the uterus, sorry, it may be limited to the cervix or it may be just on the upper part of the vagina, but less than 4 centimeter growth, more than 4 centimeter growth, more than 4 centimeter growth. Then it is chemoradiation. Very good. Then it is chemoradiation. Difference between colposcopy, hysteroscopy. Hysteroscopy, you look inside the uterus with a scope, and colposcopy is a procedure in which we can look at the cervix under magnification. We don't go inside the uterus, okay. It is like a telescope, a camera device which throws light into the cervix, into the vagina, into the cervix, and ectocervix. We can look at that. We can have a look at the vagina, and we can look at, it's like a camera, it's like a telescope like this, okay. And you can see the image here, or you can connect it to the video colposcope, and you can get a computer image also. So there are different kinds of colposcopes, right. Basically help to see the vagina, the cervix under magnification, the ectocervix mainly. And you can see the vulva under magnification also, right. Next set of one-liners. Overall, most common histological type of ovarian cancer. So, in the recent INI-CET, they had asked this question. They had given a clinical profile of a woman with non-specific gastrointestinal symptoms, right, long-standing symptoms, and then ascites, and they had given bilateral adnexal masses, solid cystic areas, solid areas on ultrasound, and they had asked you the histology, and they had told that CA125 is positive. CA125 is a marker for epithelial ovarian cancer. This marker is more useful in older women. This marker is more useful in postmenopausal women. It is serous cyst adenocarcinoma. Serous histology is the most common histology. Then please remember mucinous histology if they have to ask. They will mention loculi filled with mucin, often huge sizes, often unilateral. They have better prognosis as compared to serous. The tumor marker is CEA, CA99, and it can be associated with pseudomyxoma peritoni, pseudomyxoma peritoni. You see these things, then your answer is mucinous histology. Okay, next one liner, most common germ cell cancer of the ovary. Most common germ cell cancer of the ovary. Yes, most common germ cell cancer of the ovary. Yes. Dysgerminoma, yes, dysgerminoma is correct. If that is not in the option, then immature teratoma. If that is not in the option, then immature teratoma, right? And please remember the marker for dysgerminoma. Marker for dysgerminoma. If they are telling you that there is a young girl with ultrasound features of malignancy in the adnexal mass, and they are telling you raised LDH, placental alkaline phosphatase, HCG could also be raised, but mainly LDH and placental alkaline phosphatase. AFP is never raised. AFP is never raised. Answer should be dysgerminoma. Answer should be dysgerminoma. ठीक है, अब एक क्लिनिकल बात कर लेते हैं. क्लिनिकल बात ये है कि देयर इज अ वुमन, ओके, एंड शी इज हैविंग adnexal mass. ओके, adnexa में masses है, हमने अल्ट्रासाउंड कर लिया, एंड ऑन अल्ट्रासाउंड वी आर गेटिंग सस्पिशियस दैट इट कुड बी मलिग्नेंसी. पेशेंट की क्लिनिकल प्रोफाइल भी ऐसी है, मास adnexal masses बहुत ह्यूज हैं, अल्ट्रासाउंड में हमें सस्पिशन है इट कुड बी malignant. ओके, देन first of all, whenever there is suspicion of malignancy, we should operate. Priority wise, we should operate, but we should always send tumor marker. Because 100% confirmation whether a given ovarian mass is malignant or not, we will get once we remove the mass and have a histopath. Okay, so in younger women, we have to send the tumor marker profile accordingly. In older women where we have epithelial ovarian cancers, we have to send the tumor marker profile accordingly. So keep that in mind also. This is conceptual. Okay, next one liner, next set of one liner. Ovarian cancer, they can give you a profile of ovarian cancer associated with maybe in a younger woman abnormal uterine bleeding. They may tell you that there is a young pubertal girl with somebody with precocious puberty. They may tell you it is a postmenopausal woman with postmenopausal bleeding. Some bleeding they tell you. This is granulosa cell tumor. This is granulosa cell tumor associated with raised estrogen level, secretes estradiol. The tumor marker for granulosa cell tumor is inhibin. Inhibin B is the tumor marker. Okay, now ovarian cancer associated with virilization, the ones that will produce androgens. So yes, you are right, arenoblastomas, and the example would be Sertoli cell and Leydig cell tumor. Sertoli cell and Leydig cell tumor. Sertoli Leydig cell tumor. Let me just declutter my slide. Next one liner, Meek syndrome. Meek syndrome is ascites, pleural effusion plus what? Plus fibroma. Ovarian fibroma which is benign. Originally Mr. Meek described this in an ovarian fibroma. Okay, so it has to be a benign ovarian tumor which most of the times is a fibroma. So please remember this, right? And pseudo-Meek syndrome is the same thing but with some other histology. Pseudo-Meek syndrome is the same thing but with some other histology. Okay. Next set of one-liners quickly. Shoulder dystocia is head to body delivery time more than how many seconds, and there is an associated sign of shoulder dystocia. So basically, in clinical practice, nobody really waits for this. Nobody counts the watch now that how much time has gone by. But once the head is delivered, the shoulders does not immediately come out, and we see an associated sign. So that's the logic. So shoulder dystocia is head to body delivery time more than 60 seconds. It is associated sign with turtle sign. right? The head comes out and then recedes back onto the maternal perineum. That is what turtle sign is. The moment we see this, the first thing that we do is to go for the Mac-Robert maneuver. Mac-Robert maneuver, as you see in the image. In Mac-Robert maneuver, please remember thighs on abdomen. Okay, thighs on abdomen, maternal thighs on abdomen, that is Mac-Robert maneuver, right? Flexion and abduction of the thighs. Okay, then assistant also gives suprapubic pressure, that is another thing. Okay, but first maneuver you have to do is Mac-Robert maneuver, that is priority. Okay, and suprapubic pressure can be added. Suprapubic pressure can be added. Okay, now next question. ROP in labor, DTA in labor, face to pubis delivery is done when? 3 set of one-liners. ROP in labor management. ROP in labor. You are given a situation, they ask you there is a right occipito-posterior position in labor. Wait and watch. Allow her to progress on her own. Okay, until and unless the labor gets stuck or something. If they are saying DTA in labor, deep transverse arrest in labor. Deep transverse arrest in labor. Best management for deep transverse arrest in labor? Yes, cesarean section. Best is cesarean section. Okay, deep transverse arrest, usually the station will be high. There will be no instrumental delivery, no forceps delivery, nothing of that sort. It has to be cesarean section. Face to pubis delivery is possible in direct occipito-posterior position, provided that there is, a spacious pelvis. Direct occipito-posterior position usually associated with anthropoid pelvis. Anthropoid pelvis. AAP, antero-posteriorly oval. Antero-posteriorly oval. That is anthropoid pelvis. Persistent mento-posterior. If they are mentioning persistent mento-posterior, bro presentation or transverse lie in labor, management is cesarean section. With persistent mento-posterior vaginal delivery is not possible, mento-anterior vaginal delivery is possible. Persistent bro presentation in labor, vaginal delivery is not possible. Transverse lie in labor, they may say shoulder presentation, transverse lie is shoulder presentation. In labor, management is cesarean section, even if the baby is dead. So, if vaginal delivery is not possible, there is no scope of any destructive procedures in obstetrics anymore, right? So, your destructive procedures are not the answer. Please remember that. Next set of question. Yes. Most common cause of breech presentation and transverse lie. So, it could be breech presentation they are asking, they could be asking transverse lie. The answer is prematurity. If they say most common cause of transverse lie at term, answer is placenta previa. Placenta previa. Okay. If they ask you highest risk of cord prolapse, transverse lie, if it is in the option, that's your answer. Then footling breech, then flexed breech, and then frank breech, Okay. Now, look at this. You are asking now. Who was asking about ECV करेंगे क्या? तो breech presentation or transverse lie at term, external cephalic version after fulfilling the criteria. So, it should be offered to all women. It should be offered to all women who fulfill the criteria. So, remembering the criteria is most important. This is image showing external cephalic version. Singleton fetus. If multiple pregnancies there is no external cephalic version. Pelvis adequate. If inadequate pelvis, external cephalic version not an option. Pelvis inadequate is itself a direct indication for cesarean section. Placenta not low lying. Placenta should be not low lying. Placenta should be in the upper segment. If it is a low lying placenta, if it is a placenta previa, it is by itself a direct indication for cesarean section. There is no external cephalic version. Liquor should be adequate. Membrane should be present. Right? Because if oligohydroamniosis there, membranes are absent, leaking is happening, oligohydroamniosis there, baby, you can't move the baby. There is very high risk of cord compression while moving the baby and everything. So, liquor has to be adequate. You remember the criteria, you remember the contraindications also. And healthy mother should be there, healthy mother should be there, and healthy baby should be there. So, basically if the baby is already compromised, then I don't want to do. Right? When the baby is already compromised, then I don't want to do. Healthy mother should be there, meaning there should be no hypertension, there should be no preeclampsia. Okay? Or next one-liner question. If you have a situation where they are telling you foot-link breach, they are telling you breach in labor and they are telling you that you can only feel the feet, buttocks are high up, or they are saying foot-link breach, or they are telling you breach with hyper-extended head, then your management is cesarean section. Then your management is cesarean section. And the only indication for internal podalic version in entire obstetrics is delivery of second twin in transverse lie. That is the only indication for internal podalic version in obstetrics, second twin in transverse lie. Right? Next set of one-liners. Okay, fine. And यार हिना मैं बोल भी रही हूँ, अभी हैंड राइटिंग क्या हो गया कि थोड़ा थोड़ा लास्ट के 20 बचे हैं, ठीक है, बट व्हेन आई गिव यू द नोट्स ना आई मेक श्योर दैट द हैंड राइटिंग इज बेटर, ठीक है, पीडीएफ में. चलो आगे बढ़ते हैं. नेक्स्ट सेट ऑफ वन लाइनर क्वेश्चन सारे देख लेते हैं, सारे लिख लेते हैं, फिर बात करते हैं, ठीक है. ऑलराइट, ड्रग ऑफ चॉइस, दीज आर एब्सोल्यूट कॉन्ट्राइंडिकेशंस. अरे बच्चे जो मैं लिख रही थी, बता रही थी, कहाँ गया ये तो सिंगलटन होना चाहिए, पेल्विस एडिक्वेट होना चाहिए, प्लेसेंटा नॉट लाइंग होना चाहिए. ये क्राइटेरिया है, क्राइटेरिया टू बी फुलफिल्ड, ये क्राइटेरिया थे, ठीक है. चलो आगे बढ़ो. ओहो, okay, most common type of twins. So dizygotic are more common than monozygotic. Dizygotic are the ones that are already two separate zygotes to begin with. Dizygotic are always going to be dichorionic, diamniotic. So that is why most common type of twins are dichorionic, diamniotic. Monozygotic can also be dichorionic, diamniotic when division takes place within 3 days of fertilization. Right, so monozygotic, depending upon the timing of division, can be dichorionic, diamniotic when division takes place within 3 days of fertilization. ठीक है, तो अब हम फास्ट चल रहे, क्यों? क्योंकि हमें इन्हीं पॉइंटर्स के साथ मल्टीपल चीजें रिकॉल करनी है, ठीक है, वरना ये सारे के सारे अलग अलग आपको रैपिड रिवीजन में भी अलग टेबल्स में दिए हुए हैं. राइट, तो रैपिड रिवीजन के वीडियोज में ये सब अलग अलग टेबल्स में दिए हुए हैं. इसके अलावा मोनोकोरियोनिक के साथ, मोनोकोरियोनिक के बारे में क्या यूनिक चीज है? दैट twin to twin transfusion syndrome, twin anemia polycythemia syndrome and acardiac twin. These are complications which are specific to monochorionic type of twins. Right, now please remember that monochorionic diamniotic type of twin occur when division takes place between 4 to 8 days of fertilization. ये extra point है. Complication that are specific to monochorionic monoamniotic twins, इनमें बीच में intertwin membrane नहीं है, तो इनके cord आपस में उलझ सकते हैं. So cord entanglement. Monochorionic monoamniotic type of twins occur when the division takes place between 8 to 12 days of fertilization. When division takes place beyond 12 days of fertilization, we get the monochorionic monoamniotic plus conjoined twins, right? Now, please remember, complication specific, अब देखो कैसे ये complication specific to monochorionic monoamniotic twin, cord entanglement, cord दोनों की आपस में उलझ सकती है, फिर cord compression हो सकता है, they can get interlocked, it's like hugging, the two twins are hugging each other, they can get interlocked, they are at high risk of dying, they cannot be delivered vaginally, so always delivered by cesarean section, and we prefer to do elective cesarean section, plan करके करते हैं elective cesarean section between 32 to 34 weeks after giving them steroid cover. आफ्टर गिविंग देम स्टेरॉइड कवर प्लान करके करना रहता है, ठीक है। फिर पूछते हैं मोस्ट कॉमन लाई इन ट्विन, मोस्ट कॉमन लाई दो है अंदर, कैसे पड़े हैं मोस्ट कॉमनली, बोथ लॉन्जिट्यूडनली, ठीक है, बोथ लॉन्जिट्यूडनली, ज्यादातर बोथ आर किफैलिक, बोथ आर वर्टेक्स प्रेजेंटेशन। फर्स्ट ट्विन, प्रेजेंटिंग ट्विन, जो आगे आ रहा है, जो पेल्विस में पहले घुस रहा है, दैट ट्विन, फर्स्ट ट्विन, प्रेजेंटिंग ट्विन, अगर वर्टेक्स है, इट्स वेजाइनल डिलीवरी। Okay, so first twin vertex, second also vertex, vaginal delivery. First twin vertex, second breach, vaginal delivery. First twin vertex, second transverse, vaginal delivery can be attempted. As long as first twin is vertex, it's vaginal delivery. It's first, if the first twin is anything other than vertex, first twin breach, first twin transverse line, anything other than vertex, it is cesarean section. It is cesarean section, right? Now, next set of one-liners. Best for determining chorionicity. Best for determining chorionicity is ultrasound. Antenatally, I want to determine chorionicity, antenatally ultrasound. Twin peak sign, lambda sign is seen in dichorionic, diamniotic type of twins, and T sign is seen in monochorionic, diamniotic type of twins. The best time to do this ultrasound for chorionicity is between 10 to 14 weeks, is between 10 to 14 weeks, right? Now, let's have a look at the next set of one-liners. 10 more to go. Okay. Postmenopausal bleeding, postmenopausal woman with prolapse, vaginal hysterectomy with pelvic floor repair has to be done, right? So, pelvic floor prolapse, ये prolapse की surgeries पे सवाल पूछते हैं one-liners generally. Pelvic floor repair, what does it means? It means anterior colporrhaphy. Please remember, anterior colporrhaphy is what we say cystocele repair. Cystocele repair. Okay. Posterior colporrhaphy. Posterior colporrhaphy is rectocele repair. I'm not writing it down, but I'm telling you. Posterior colporrhaphy is rectocele repair, and perineorrhaphy, perineal body repair also. Perineorrhaphy. Anterior colporrhaphy, posterior colporrhaphy, perineorrhaphy, whatever is needed depending upon what are the defects, right? What are the defects, depending on that, what is needed will be done. So, vaginal hysterectomy with pelvic floor repair. And procedure to suspend the vault and enterocele repair. There is a procedure that we do which will help me repair the enterocele also, which will help me suspend the vault also. That is called as McCull-Culdoplasty. Just remember the name. Undergraduate students, we don't want much, right? And Ward Mayo is a technique of doing vaginal hysterectomy, right? Where Ward Mayo's hysterectomy, there's many techniques of doing vaginal hysterectomies. One of them is Ward Mayo's vaginal hysterectomy, right? Now, young multiparous woman, family complete, wants to retain the uterus. Generally, they have supravaginal elongation of the cervix. So, multiparous, family complete, but want to retain the uterus. It is Manchester repair. It is the same as Fothergill surgery. Fothergill's repair, Manchester repair is the same. Okay. Surgery for nulliparous prolapse. See, in Manchester repair or Fothergill's repair, the cervix is amputated. So, it is not an option for women who want to have kids in the future. Okay, so surgery for nulliparous prolapse is either sling surgeries, and another one is the sacrohysteropexy. Sacrohysteropexy. Okay, best surgery for vault prolapse, sacrocolpopexy. It is a mesh surgery where the mesh, it's actually a Merceline mesh which is attached from the sacrum to the, like there's a vault here, this is from the vaginal vault to the sacrum posteriorly. So mesh will be attached. Okay, and in the RR videos they are, with the diagrams they have been shown. Now the procedure of choice for SUI, stress urinary incontinence. What is stress urinary incontinence? You should know. Okay, increase in intra-abdominal pressure, activities like sneezing and coughing and laughing and lifting heavy weight and all those sorts of things, and the few drops of urine pass out, that is stress urinary incontinence. Okay, it's very common. It is overall the most common type of incontinence in women overall. But as the woman gets older, see, if you're not listening to me, then there is no point, right? As the woman gets older, what will happen? Urgency will also happen. So when you have older women, overall, among all age groups of women, SUI most common. If they specifically ask you, women older than 60 years, she is having incontinence, most of the times it is mixed incontinence. Mixed meaning some component of stress is also there, urgency incontinence component is also there. Urge incontinence means that, she can't, whenever she'll get this sensation of bladder fullness, she'll like want to pee, and by the end she'll have such a sense of urgency, inability to hold, she'll rush to the toilet, and before only, some drops of urine will leak out. So that is urgency incontinence. Anyways, procedure of choice for SUI is mid-urethral slings. Mid-urethral slings. So in mid-urethral slings, you have the TOT and the TVT. TOT and the TVT. And Yugal, it is very difficult to say whether TOT is better or whether TVT is better. They both have their own advantages vis-a-vis disadvantages, right? So it is really difficult to say which is better. And Burch-Kolpos suspension is another surgery for stress urinary incontinence, but nowadays it is not the procedure of choice. Okay, Burch-Kolpos suspension is another surgery for SUI, but nowadays mid-urethral slings have become the procedure of choice. Last set of one-liner question pointers. History, this is from your recent FMGE examination in January. So I have got this question. History of obstructed labor with constant dribbling of urine from vagina. She is in puerperium. Profile alag ho sakti thi. It could have been a woman after hysterectomy, and post-operative day 7 to 10. Generally post-operative day 7 के बाद ही होता है. So delayed presentation. Post-operative delayed presentation of constant dribbling of urine from vagina and unable to hold urine. What is the diagnosis? Constant dribbling of urine is not stress urinary incontinence. Constant dribbling of urine, and she is not even able to hold urine. Whatever is filling in the bladder is coming out of the vagina. It is most likely a vesico-vaginal fistula. The other clue is that there is history of obstructed labor. So history of obstructed labor means there could be ischemic. This is basically ischemic necrosis happens, no? Right? Because there's pubic symphysis in front, baby's head in the vagina, and then the bladder and the urethra compressed in between these two bony prominences. Ischemic necrosis in this area, vesico-vaginal fistula. Right? And please also remember that many times we will be able to see this fistula. Yes, so Abhishek, you mentioned correctly. You mentioned 3-swab test, and Shiv Pratap is saying cystoscopy. Yes, best investigation for VVF is cystoscopy. Okay, because what we can do is we can go inside the bladder with the cystoscope and look at the fistulous opening in the bladder. Okay, 3 swab test is done in the OPD basis. 3 swab test से हमें इतना ही पता चलेगा, देखते क्या पता चलेगा. This is the vagina. This is the vagina. Okay. We fill it with 3 swabs. And let's say this is the bladder. We fill the bladder with methylene blue dye. And then we ask the woman to walk around for some time and then come back, and then we remove the swabs. See, if this swab is staining blue, if this swab is staining blue, if the uppermost swab is blue, it is vesicovaginal fistula. Lowermost is blue, it is urethrovaginal fistula. बट प्लीज समझो ये बात को कि ये डिफ्यूज, ये सारे भी ब्लू हो सकते थे ना. सबसे ऊपर वाला वेट हुआ, उसके चलते बीच वाला भी वेट हो सकता है. सबसे नीचे वाला वेट हुआ, फिर वहां से ये भी सोख हो गया. तो मोटे मोटे तौर पे इतना ही पता चलता है कि हाँ वीवीएफ हो सकता है. अपर मोस्ट वाला अगर सिर्फ स्टेन है तो वो वीवीएफ की तरफ इशारा कर रहा है. इट इज पॉइंटिंग टूवर्ड्स वीवीएफ. ओके, तो ये हमें पता चलेगा. एंड इफ लेट्स से देयर वाज अ यूरेटरोवेजाइनल फिस्टुला, ये यूरेटर से आ रहा है. देयर वाज अ यूरेटरोवेजाइनल फिस्टुला, देन यूरिन विल कम, they will be wet with urine, but not blue, this is the valid information that you will get. So if we want to see that where exactly in the bladder, where exactly in the urethra, where is the fistulous opening, how many fistulas are there, that level of accurate information, cystoscopy. Ureterovaginal fistula, mostly ureterovaginal fistula are post-surgical. During surgery, injury to the ureter happened, ureter was crushed in between the clamps, ureter was tied or whatever, and some ureter injury happened, unidentified, surgeon did not repair, later on, post-operatively, ureterovaginal fistula developed. So, constant dribbling of urine will be there. But the patient will be able to hold urine. Okay, patient will be able to hold urine as well. Okay, when there is a ureterovaginal fistula. Here they have asked you this question: which hysterectomy has the least risk of ureteric injury? Vaginal hysterectomy. ठीक है, अब इसको रट लो. ठीक है, हम जब वेजाइनल हिस्टेरेक्टमी करते हैं तो एक ऐसा होता है कि यूट्रस को हम नीचे पुल करके वेजाइनल हिस्टेरेक्टमी कर रहे होते हैं, तो यूरेटर दूर चला जाता है एनाटॉमिकली. राइट, सो वेजाइनल हिस्टेरेक्टमी हैज द लीस्ट रिस्क ऑफ यूरेटरिक इंजरी. ये आपका रिसेंट एफएमजी में सवाल आया था. ऑप्शंस थे वेजाइनल हिस्टेरेक्टमी, एब्डोमिनल, लैप्रोस्कोपिक, इस तरीके से. हिस्टेरेक्टमी विद मैक्सिमम रिस्क ऑफ यूरेटरिक इंजरी आर रैडिकल hysterectomies which are done for cancer surgeries, जिसमें we do a lot of lateral dissection, right? So ureter वही है उसी एरिया में, lateral pelvic wall पे. तो radical hysterectomies are the hysterectomies with maximum risk of ureteric injury. और एक last question यहाँ पे था, management of decubitus ulcer. प्रोलैप्स सर्जरी से पहले decubitus ulcer is a venous congestion ulcer. Decubitus ulcer is a type of venous congestion ulcer, right? Management has to be done. It has to be vaginal packing with glycerine and acreflavin. Spare my handwriting. Okay, for now. Decubitus ulcer, venous congestion ulcer, vaginal packing with glycerine and acreflavin. Yes, Yugal, अगर वर्दाइम्स है ऑप्शन में तो वर्दाइम इज अ टाइप ऑफ रैडिकल हिस्टेरेक्टमी. ठीक है, तो डेक्यूबिटस अल्सर का पहले ट्रीटमेंट होगा, पहले डेक्यूबिटस अल्सर हील होगा, उसके बाद ही कोई सर्जरी होगी. राइट, सो डेक्यूबिटस अल्सर भी आपसे पूछा जा चुका है, दैट हैज बीन आस्क्ड. So broadly these are the 100 one-liners and we are wrapping it up, okay, for now. Before I started the session for today, I told you that if you want to look up, see, amenorrheas, Okay, amenorrheas, abortions, ectopic, genital tract infections, obstetric emergencies. Right? I have discussed them in the LRR sessions also in detail. Okay, so that is why I did not include them in today's this thing. ठीक है, तो आज ये नहीं डिस्कस हुए हैं, ये बहुत डिटेल में LRR सेशंस में डिस्कस हो चुके हैं ये वाले टॉपिक्स. ये यूट्यूब पे अवेलेबल हैं ये दोनों सेशंस, आप वो देख लो अपने FMGE के लिए. आप ये 100 वन लाइनर्स कर लो, राइट. एंड some of the other topics like there are certain mixed bag topics जैसे कि प्यूपेरियम के कुछ important प्यूपेरियम आपके एग्जाम के लिए important है. और वन ऑफ क्वेश्चंस आते हैं जैसे कि कभी ड्रग्स इन प्रेगनेंसी में आ जाते हैं, मेडिकल डिसऑर्डर से रिलेटेड क्वेश्चंस आ जाते हैं. वो आप RR वीडियोस में अगर मेरे देखोगे जो ऐप पे हैं, वहां पे एक मिक्स्ड बैग सेशन, मिक्स्ड बैग जो है वो डिस्कस हुआ है, राइट. लूटियल फेज डिफेक्ट, अरे यार लूटियल फेज डिफेक्ट, you know why I reacted like that to luteal phase defect, because मैं अभी देखती ही नहीं हूँ किसी में clinically, frankly speaking, because इसका ना कोई बहुत ज़्यादा डिटेक्शन करने का बहुत अच्छा तरीका है हमारे पास आज की डेट में, ना हमारे पास कोई बहुत अच्छा इसका कोई ट्रीटमेंट वगैरह है लूटियल फेज डिफेक्ट का. मोटे मोटे तौर पे व्हाट लूटियल फेज डिफेक्ट मीन्स इज डॉक्टर वेद दैट यू नो that the menstrual cycle is operating, right. So वो आपका अगर जैसे ओव्यूलेशन हो गया उसके बाद लूटियल फेज में आ गया तो एंडोमेट्रियल की डेटिंग होती है, एंडोमेट्रियल के डेवलपमेंट की डेटिंग होती है. कहने का मतलब ये है कि डे 15 में एंडोमेट्रियम ऐसा होगा, डे 21 पे ऐसा होगा, डे 25 पे ऐसा होगा, ये फाइंडिंग्स होंगी, यू नो, इस तरीके से. तो ये एंडोमेट्रियल डेटिंग हो गई. और कॉर्पस लूटियम से प्रोजेस्ट्रॉन सिक्रीट हो रहा है, राइट. और वो कॉर्पस लूटियम की हेल्थ पे डिपेंड करता है कि कितना प्रोजेस्ट्रॉन आ रहा है, राइट. तो मेंस्ट्रुअल डेटिंग के हिसाब से कि आज डे 21 है तो क्या एंडोमेट्रियम में भी वही फाइंडिंग्स हैं डे 21 वाली, या एंडोमेट्रियम लैग बिहाइंड कर रहा है, अभी एंडोमेट्रियम डे 21 वाली फाइंडिंग के लायक हुआ ही नहीं है, इस तरीके की बात होती है. सो दैट इज व्हाट लूटियल फेज डिफेक्ट मीन्स. मे बी इनसफिशिएंट प्रोजेस्ट्रॉन सिक्रीशन, अनहेल्दी, बड़े सारे इसमें पेचीदगी हैं. मोटे मोटे तौर पे यही है कि भाई histological dating of the endometrium and the date of the cycle वो सिंक में नहीं है, ये है मतलब. ठीक है, all right. So with this we finish off the lecture for now. बच्चे लोग 5:30 बजे से बैठे हैं, हम बड़ी मुश्किल से बैठ पाए थे यूट्यूब पे, फिर अब 8:30 हो गया है. आई थिंक वी शुड टेक रेस्ट नाउ. एंड अदर सब्जेक्ट वन लाइनर्स आपको ऐप पे मिल जाएगा शेड्यूल, और आपके ग्रुप्स में भी शेड्यूल शेयर हो जाएगा. डोंट वरी अबाउट द PDF, बट यू विल हैव टू गिव मी टाइम टू क्रिएट अ वेरी नाइसली ब्यूटिफुली रिटन PDF फॉर यू, राइट. तो PDF कमिंग डेज में बाय टुमारो, अर्लीस्ट बाय tomorrow or day after will be shared with you people, so do not worry about that. Okay, chalo फिर now let's end the session for today. There are no further doubts and queries. Thank you guys. Keep revising, keep revising, keep revising, keep doing MCQs. Retrospective करो. आउट ऑफ द ब्लू क्वेश्चंस पे टाइम वेस्ट मत करना. डोंट वेस्ट टाइम ऑन आउट ऑफ द ब्लू क्वेश्चंस, या जो कभी कभार पूछे गए हैं, मत टाइम वेस्ट करो. अब जितना हो सके प्रीवियस ईयर टॉपिक्स को रिवाइज करो, राइट. लेट्स गो. चलो, गुड नाइट गाइस, टेक केयर.